Hello guys, good evening and greetings everyone. Welcome back to another session and happy Dasara to everyone first of all. In the first place, I think you can all hear and see me in the first place. Can you see me and hear properly without any problem? Yeah, Keshav. Happy Dasara. Happy Dasara to everyone. Hope you are celebrating Dasara properly in home. And can you see and hear me? There are 30 plus participants are there right now. So I think they all are able to see and hear properly. Can you? Cool. Okay, you can hear and see properly. Fantastic. So we're going to start from where we have left today. I think yesterday we are on the way to start C. I mean, we have started CKD, but we have seen some problems with regards to chronic kidney disease, and we have not yet discussed on the other aspects of CKD yet. So we need to know about the treatment of CKD, which is actually quite simple, and some few complications that are specific to CKD. We'll do that as well, and later on we'll be moving ahead with the transplant and probably the modalities of dialysis that is available for CKD patients. So let us start with that in the first place. So as far as the treatment of CKD is concerned, so we are going to CKD treatment. As for the treatment of CKD is concerned, the first thing to know is when to refer the patient to dialysis. That is really, really important. Apart from that, we also need to know when to really refer the patient to a transplant, which also has been mentioned in the previous session itself. Like I've told clearly that when the patient reaches that fourth stage of CKD, always refer the patient to, prepare the patient for a dialysis. And when the patient reaches that end stage renal disease, CKD stage 5, basically are going to think whether this patient is a transplant candidate or not and prepare the patient for a transplant if possible. That's what they're going to do. Apart from that, so there are some problems that are naturally going to happen in CKD. The one thing that I want to really take care is the cardiovascular risk, because cardiovascular risk is something that is there for all CKD patients, irrespective of the cause and irrespective of the treatment type. And at the same time, this is the leading cause of death in patients with CKD. It could be heart failure, pulmonary edema, or it could be LVH, cardiomyopathy, MI. So some cardiovascular problem is going to kill the patient for sure. So how can you reduce the cardiovascular risk? You have to reduce the risk by probably giving statins, even though the current ACC/AHA guidelines do not tell whether all CKD patients should receive statin or not. Statin as a primary prophylaxis is not really, like an evidence-based thing. But for secondary prophylaxis, still yes, of course. A patient is a known case of CAD, you're going to give statins. But if the patient is not a known case of CKD, CAD or any other atherosclerotic cardiovascular disease, then giving statins is quite controversial, which means we're talking about a primary prophylaxis, which is controversial. Secondary prophylaxis, yes, you can give. So there's no doubt about that. Statins are absolutely indicated, and at the same time, you can give beta blockers as well. But antiplatelet agents as primary versus secondary prophylaxis, once again, is not clear. So, for example, if we take antiplatelets like clopidogrel, aspirin, or any other antiplatelet drugs, again, primary prophylaxis is controversial. We cannot give. Secondary prophylaxis, of course, yes, you can give a secondary prophylaxis. And again, different bodies say different thing. So controversial in the sense, ACC/AHA, it's just they do not mention anything about CKD and statins. But whereas KDIGO guidelines are saying for primary prophylaxis, yes, you can give statins, no problem. So in exam, if somebody asks whether I can give statins in a patient with CKD and primary prophylaxis, based on the KDIGO guidelines, I can go yes. And the secondary, there is no doubt about that. Surely yes. As far as the antiplatelet agents are concerned, antiplatelet agents as primary prophylaxis, again controversial, because no guidelines are clearly telling whether to give or not. So it's a clear no. There's no doubt about that. But as a secondary prophylaxis, definitely yes. Why we don't really give antiplatelet agents as primary prophylaxis? Because we are worried, because CKD patients are already at risk of developing severe bleeding because of uremic platelet dysfunction, and giving an antiplatelet agent may not be very ideal really. So that is why majority of the guidelines do not tell yes or no, but most of them tell no for antiplatelet agents as a primary prophylaxis. But for secondary, yes, the patient is already having an atherosclerotic cardiovascular disease, then surely yes, you have to give. Next, second, your diet is very important as far as CKD is concerned. So this is a multiple times asked question. What are the diet you're going to give? Of course, you're going to give a low sodium diet, and at the same time, you are going to give a low potassium diet. That's very, very important because CKD patients are typically prone for hyperkalemia. And at the same time, you need to give a low phosphorus diet. And next is the protein. Protein is quite controversial. It's not low protein or high protein. We tend to give a moderate protein diet. But once again, there are certain guidelines which tell, suppose if the patient is a CKD patient but not on renal replacement therapy, patient is not on dialysis, not on renal replacement therapy, then this patient actually has to take lesser protein. Like for example, the recommended guidelines are zero point 0.8 to zero point 0.9 gram per kilogram per day. The usual RDA, that is recommended dietary allowance of protein, is 1 gram per kilogram per day, but it is slightly less in patients who are not on renal replacement therapy. And CKD patients who are on renal replacement therapy, in these guys, basically you need to give a little bit of higher proteins, like probably 1.1 to 1.3 grams per kilogram per day. So this is the recommended protein. So patients who are on RRT, you tend to give a little higher protein because they are prone for malnutrition, and patients who are not on any dialysis, you can give a slightly lesser protein than recommended. But nevertheless, this is not a strong recommendation, but overall the current guidelines recommend you to give a moderate amount of proteins as far as the CKD is concerned. And similarly, this potassium is also quite controversial, whether all the patients should receive low potassium diet or not. Again, so if the patient is oliguric or if the patient is already hyperkalemic, then this low potassium diet is advocated. If the patient is non-oliguric and if the patient is having a normal potassium, so many guidelines suggest like you can take a normal protein diet also, not a big deal. And similarly, there is a lot of controversy as far as the fluid is concerned. How much fluids to take? How much fluids to take? Fluids, we don't really have much recommendation. You can give even a normal amount of fluid, doesn't matter. Suppose if the patient has hyponatremia, that is due to hypervolemic hyponatremia, volume overload state. So in that setting, you can restrict fluids. But apart from that, again, fluid restriction is quite controversial. Depends on what stage of CKD you're dealing with, and depends on what is the clinical status of the patient. If the patient is ESRD, of course, I'll be giving a fluid restriction. If the patient is only in an early stage CKD, generally I don't want to restrict fluids to a great extent because they'll be non-oliguric and they'll be doing okay with this fluids as well. So fluids is again dependent on the stage of CKD and as well as the clinical status of the patient. As far as low sodium is concerned, there are two indications where the low sodium is must. One is of course volume overload state, and second one is hypertension. The patient has hypertension and the patient has volume overload, low sodium is a must. Many of these patients will have hypertension, volume overload, so of course I need to give a low sodium diet. So if somebody asks you what is the diet, I'll be giving low sodium, low potassium, low phosphorus, and moderate protein, and probably a fluid restricted diet if the patient is in ESRD stage. But apart from that, again, fluids are quite variable. So this is the diet I need to prefer as far as the CKD patients are concerned. And number three, controlling the basic problems, like for example diabetes, hypertension. So how you're going to control diabetes, how you're going to control hypertension, and what will be the cholesterol levels. So diabetes is quite difficult to control, quite difficult to manage when the patient enters CKD. The reason is because there is a higher chance of hypoglycemia in patients with diabetes mellitus when they go for CKD. So why there is a higher chance of higher chance of hypoglycemia? Because patients might not adequately eliminate the metabolites formed by certain compounds like sulfonylureas, and patients may not really metabolize insulin properly. And at the same time, kidneys also do gluconeogenesis to some extent because they do have this glucose 6 phosphatase enzyme. Remember, glucose 6 phosphatase enzyme is present only in three areas: large extent in liver, to some extent in kidneys, to a very little extent in intestine. Muscles does not have glucose 6 phosphatase enzyme, so these muscle cannot participate in gluconeogenesis. But liver followed by kidneys followed by intestine to an extent can participate in gluconeogenesis in fasting state. So because kidneys are little important in gluconeogenesis, a complete kidney failure may pose the patient to a higher risk of fasting hypoglycemia. So that is the reason why you need to reduce the insulin dose if the patient is getting some insulin. try to reduce the insulin dose as much as possible. And second thing, try to avoid sulfonylureas. Avoid sulfonylureas or any other insulin secretagogues like meglitinides also. So try to avoid sulfonylureas. If suppose they ask what is the most reno-friendly sulfonylurea, this is not correct actually. It's a very old terminology. What is the most reno-friendly sulfonylurea? I'll go probably for glipizide. Glipizide is considered to be a little reno-friendly compared to other sulfonylureas, but nevertheless, I don't really want any sulfonylurea for the patient. Try to avoid sulfonylureas as much as possible. In any patient with a severe micro or macrovascular disease due to diabetes, insulin is always the best drug. So any advanced macrovascular disease, always go for insulin, nothing else. And there are some other drugs which you can give. As far as gliptins are concerned, this is DPP4 inhibitors. One gliptin is considered to be extremely reno-safe. What is a gliptin? I think everyone must be knowing this because this is asked in AIIMS already. I don't think students, especially who are preparing for NEET PG exam, will be able to forget this. What is a gliptin that is most reno-safe or probably most reno-friendly? Of course, yes. So you have to answer immediately. That is linagliptin, right? So linagliptin, because why it is linagliptin? Maybe because it's metabolized by the liver. So that's why you have the L in it. So linagliptin. So it's the most reno-friendly gliptin. You can give linagliptin. And currently, evidence says that gliptins can reduce proteinuria. As from the CKD perspective, gliptins can reduce proteinuria to some extent. So gliptins are little beneficial in patients who are suffering from CKD, especially with proteinuria. So you can give, not a problem. There are other groups of drugs which are also beneficial in CKD. For example, SGLT2 inhibitors. As far as SGLT2 inhibitors are concerned, they are supposed to be beneficial, especially your canagliflozin and empagliflozin. Dapagliflozin is not yet proved for kidney, but for heart, all these three things are beneficial. But for kidney, only canagliflozin and empagliflozin are proven to be beneficial. They are beneficial in patients with diabetic kidney disease. They're actually going to reduce the mortality. It is a direct effect. And that's why SGLT2 inhibitors can be tried in patients who are suffering from CKD because of diabetes mellitus. And if they have kidney disease, you can give. Especially this canagliflozin and empagliflozin, they slow down the progression, slow down the CKD progression. And because of the same, the gliptins also may slow down the CKD progression to a lot of extent. And what about pioglitazone? Pioglitazone has no effect on CKD, no harmful effect or no beneficial effect as well. But you need to know that pioglitazone can cause volume overload state, can cause volume retention. So a CKD patient is already having a volume overload, may get additional volume overload because of pioglitazone. At the same time, in patients with heart failure, it is contraindicated. Pioglitazone cannot be given. But apart from that, as far as the kidney is concerned, pioglitazone does not do anything at all. It is not beneficial, it is not harmful. But because of its other effects, sometimes it can be a little problematic. So avoid pioglitazone. But please understand, if the GFR is less than 30, especially in CKD stage 4 patients, avoid oral drugs and always switch to insulin. None of the oral drugs to be given if the patient is having a GFR less than 30. So the GFR becomes less than 30, please avoid oral drugs as much as possible and try to give insulin, switch to insulin, only insulin. Almost all the insulins are safe in CKD patients. It's not like you have to prefer a particular insulin, but it's just that the patient has a higher dose or higher risk of developing hypoglycemia. So it's just that you need to reduce the dose of insulin. That's it. Apart from that, try to avoid as much as oral drugs as possible. Try to shift to insulin. But more than 30, then you might try probably gliptins and SGLT2 inhibitors. Maybe I will try these drugs, gliptins and SGLT2, if the patient's EGFR is more than 30. But once it becomes less than 30, try to shut down all these drugs and try to switch purely to insulin alone. But you have to monitor very carefully. Okay. But one more problem is, once the patient becomes ESRD, and especially on renal replacement therapy, my sugars become little bit labile. So you will experience something called a labile sugars, in the sense like it's very difficult to predict the sugars. During dialysis, the sugars may fall down because dialysis itself tries to eliminate some sugar, some glucose from the body. But if the patient is on peritoneal dialysis, the sugars might actually rise on dialysis days. So dialysis days becomes a headache for me most of the times. So, like if the patient is on hemodialysis, then sugars might drop during dialysis. And if the patient is on peritoneal dialysis, sugars might rise during dialysis. So it becomes quite a headache for the patient as well as for myself. So here the treatment should be individualized, where I advocate something called SMBG. Everyone will be knowing what is SMBG. That's called the self-monitoring of blood glucose. So typically, I advocate like 3 to 4 times of SMBG per day, at least minimum, especially on dialysis days and not on dialysis days. So we'll put a chart, and thereby the insulin doses will be titrated for that particular patient. So it should be highly individualized, because especially once the patient goes for renal replacement therapy, the sugars will be extremely level, and it's very difficult to tell that this is the fixed dose of insulin for a particular patient. So that is something you have to take care about. And one more thing is, if the patient is on RRT, then HbA1c values become questionable, seriously questionable. Whether HbA1c is really beneficial at that point or not, I don't think so, because the patient will be suffering from so many other uremic complications, anemia, which can itself alter the HbA1c to a great extent. So whether if it is low or whether it is high, it's very difficult. So I cannot predict my glycemic control based on HbA1c. So HbA1c becomes a big question in a ESRD patient on renal replacement therapy. But if the patient is not on ESRD, then HbA1c levels to an extent may be okay. Especially, I can keep a cutoff of approximately 7%, even though strict cutoffs have not shown to be beneficial, because this patient was having a diabetes, developed a kidney disease because of diabetes, and is going towards an end-stage renal disease. And I don't think really, controlling the sugars after that very strictly makes some impact. So already the damage is done, and now you are only trying to mitigate, and you're not trying to actually uh, prevent the damage anymore. All that the kidney is gone. So try to keep HbA1c with a liberal cutoff of around 7.5. That's enough for me. The more I reduce the HbA1c, the more is the risk of hypoglycemia, and I'm not going to get any benefit out of it, because kidneys are already gone. He has entered a full-blown CKD. So what is the point in that? So maintain HbA1c of around 7. That's enough, but don't try to reduce the HbA1c to 6.5, which doesn't have any much impact in a patient who's already a CKD. But if the patient is not on RRT, not ESRD, then HbA1c may be reliable. But if the patient is already a ESRD patient on dialysis, especially, then your HbA1c becomes a joke, and it's always about SMBG. That is self-monitoring of blood glucose. But nevertheless, there are few questions that you can get. First question is individually. I mean, this insulin dose. What should be done? The insulin doses should be reduced in CKD patient because of the risk of hypoglycemia. And second point, avoid sulfonylureas. If at all you want to give a sulfonylurea, prefer glipizide. Number 3, gliptins have beneficial effect by reducing proteinuria so that they can slow the CKD progression. Linagliptin is the preferred drug in CKD patients because it's excreted through liver. Fourth drug is SGLT2 inhibitors. Itself can slow the CKD progression, and it's likely to be beneficial in a patient with CKD. Paldazone neutral effect, but should be avoided in patients with heart failure, and at the same time it can cause problems like producing volume overload. When the EGFR is less than 30, you need to avoid oral drugs and switch to insulin. This is question number 5. And question number 6 is HbA1c of 7% is appropriate in patients who are ESRD but not on renal replacement therapy. But in other patients, like PSRD on renal replacement therapy, SMBG is going to be the best rather than HbA1c targets. So this is all about diabetes and CKD. But before that, there is a separate entity called diabetic kidney disease. That's called a DKD. As far as the diabetic kidney disease is concerned, we have something called a Mogensen staging. Mogensen staging gives you the natural history of diabetes mellitus, natural history of kidney disease in patients with diabetes mellitus. According to Mogensen staging, you have 5 different stages as far as the diabetic kidney disease is concerned. Initially, there is a stage of hyperfiltration. Later on, they'll go for an incipient stage, then stage of microalbuminuria. Then CKD will slowly progress over years, and they will develop in a full-blown end-stage renal disease. Based on that, we have some graphical orientation also. Let us see that. So let us write the stage 1, what happens, stage 2, what happens, stage 3, what happens, stage 4, what happens, and stage 5, what happens. As far as stage 1 is concerned, this is the time where you will get this glomerular hyperfiltration, which is a characteristic hallmark of diabetes patients, diabetic kidney disease patients. So this time, during this time, the patients tend to have a increased GFR. So this is also one important reason why GFR cannot be used for screening diabetic kidney disease patients, because GFR tends to be falsely elevated in diabetic kidney disease. So you cannot use this as a marker for screening the community with GFR. So GFR is not useful for screening the community. And this is the time where the patients might have increased kidney size because of hyperfiltration, but there will be no albuminuria. No albuminuria. Clear? So in stage number 2, the patients might still be having a normal or elevated GFR. A high normal GFR is usually characteristic in this situation, but it will not be very high like in the stage 1. It will be a normal or a high normal GFR. And you will start getting certain structural changes in the kidney. Structural changes in the kidney. So what are the structural changes in the kidney? Like mesangial expansion. Some matrix might be deposited in the mesangium, and the patients may go for some local sclerosis, segmental sclerosis in the glomerulus. So capsular drop, which I've seen yesterday. So some structural changes might happen in the kidney at this point of time, but still there will be no albuminuria, or the patient might have albuminuria sporadically, like now and then. When you measure one time, there might be albuminuria. When you measure after some 2-3 days, there might not be any albuminuria. So albuminuria may or may not be there at this stage. And stage number 3 is the time where the patient will typically have a normal GFR. They won't have any problem at all. Completely normal GFR. So this time the patient will start getting more structural changes like focal segmental glomerular sclerosis, some nodular glomerular sclerosis. So the structural changes will advance a little bit, and the patient will get consistent albuminuria here. That is called a microalbuminuria. Here also I can write microalbuminuria. It can be or may not be there. And here persistently the patient will have microalbuminuria. It will become persistent here. So this is the stage where the microalbuminuria becomes persistent. That will be there for a like considerable period of time without any change. Number 4, this stage, stage 2 is what we refer to as a silent stage, and stage 3 is what we refer to as something called as incipient stage, and stage 1 is what we refer to as a stage of glomerular hyperfiltration. And stage 4 we called as an overt nephropathy stage. Overt nephropathy stage, where the GFR falls, the kidneys can no longer take, and the patient will have advanced structural changes here. Advanced and late structural changes. And this time the patient tries to have a overt proteinuria. It's not like just a microalbuminuria. The patient starts getting overt proteinuria here. In the sense, like the patient will have macroalbuminuria. So what do you mean by macroalbuminuria? If the albumin excretion is 30 to 300 milligrams per day, this is what we refer to as a microalbuminuria. Or if the albumin creatinine ratio is in the range of 30 to 300 milligrams per gram. 30 to 300 milligrams per gram. So this is what we called as a microalbuminuria. So overt proteinuria means the albumin excretion becomes more than 300 milligram per day, or the urine albumin creatinine ratio becomes more than 300 milligram per gram. So this is what we refer to as a overt proteinuria, which means it's a macroalbuminuria, no longer a micro. It does not have much significance. The patient is a CKD by now. So in stage 5, it's just an ESRD. It's end-stage renal disease where the GFR become less than 15. So the patient will be dependent on dialysis from now on. So the question will be, at what stage your hypertension will start? So BP starts rising. So usually, if they ask such kind of question, to answer stage 3. During this microalbuminuria phase, so the BP starts rising. BP starts rising, and this increased BP will persist, like in the stage 4 and stage 5 as well. So hypertension will persist in stage 4 and stage 5 as well. But increased BP typically starts, the BP starts rising step by step during the stage 3 only. And during stage 3, stage 4 and stage 5, there will be increasing other microvascular and macrovascular complications. Increased microvascular and increased macrovascular complications as well due to diabetes. So which means while they cause from stage 3 to stage 4 to stage 5, there will be more retinopathy, more neuropathy. So there will be more microvascular complications, and the patients will have higher risk of coronary artery disease and stroke as well as they move from stage 3 to stage 4 to stage 5. So the peak risk will be at stage 5 only, but as they keep moving from stage 3 to 4 to 5, the microvascular and macrovascular complication risk also will keep on increasing. Suppose if you want to put a GFR chart, so the GFR will slowly, it will be maintained till this point. So initially there will be a high GFR, then it will be maintained till the stage 3, high GFR, then normalization, it will be maintained till the stage 3. From stage 4, stage 5 onwards, it will start declining to end stage only. So this is the GFR that we're talking about. And if you take the proteinuria, albuminuria, in stage 1, there won't be much albuminuria to begin with. And in stage 2, there might be an occasional albuminuria, but after some point, it may not be there. And stage 3, there will be a consistent albuminuria. It will be in the microalbuminuric range. If you take this, the microalbuminuric range, after that, there will become a overt proteinuria. So this is the albumin, urine albumin excretion. So you can see this is the microalbuminuric range. So there can be occasional microalbuminuria in patients who are having stage 2 disease, but as they move towards stage 3, stage 4, and stage 5, the albuminuria will be persistent, and which will again shift to something called as a overt proteinuria or a macroalbuminuria. And as you, when you ask about the time, so at what time it happens as an average, so usually majority of the patients will have hyperfiltration at the time of diagnosis. This is for type 2 diabetes mellitus, and usually it takes around approximately 5 years to develop the stage 2 disease. That is the silent stage, where there will be a sporadic occasional microalbuminuria alone. And after that, it takes around 15 years to develop stage 3, and it takes around 20 to 25 years to develop stage 4, and it's around 25 to 30 years to develop ESRD. This is the natural history. It again depends, but this is the usual natural history. So at time of diagnosis, stage 1, around 0 to 5 years stage 2, 5 to 15 years it is stage 3, and around 20 to 25 years it is stage 4, and around 25 to 30 years it is ESRD. So this is the usual natural history of diabetic kidney disease, and this is what we refer to as something called as a Mogensen staging of a natural history of diabetic kidney disease. Remember, diabetes is the leading cause of CKD in the world, diabetic kidney disease. And how can you prevent this diabetic kidney disease? And if they ask you the treatment of choice for proteinuria in diabetic kidney disease, of course, I'm going to give either ACE inhibitors or angiotensin receptor blockers. Plus, along with it, many new drugs like gliptin, linagliptin, and our SGLT2 inhibitors are also beneficial in slowing down the progression of CKD. And to slow down the progression of CKD, you need to give strict glycemic control in the beginning itself, rather than controlling at the late, which is not of any benefit. You can start controlling in the beginning itself by giving along with ACE inhibitors or ARB. Suppose if they ask you in stage 3, when the BP starts increasing, what is the drug of choice? Once again, any patient with diabetic kidney disease getting hypertension, I will use only ACE inhibitors or ARB. So ACE inhibitors or ARBs are the gold standard for treatment of diabetic kidney disease, as well as hypertension in diabetes patients, as well as any CKD patient with proteinuria. ACE inhibitors and ARBs are the gold standard, and I'm going to start with ACE inhibitors for sure. So then I have to control the blood pressure, right? So number 4 is the blood pressure, BP control. So BP control is very important because hypertension worsens the CKD control. CKD worsens the CKD progression. It will accelerate the CKD progression. So BP has to be, and if they ask you the target BP, it is less than 130/80, the latest ACC-AHA. But even though the previous guidelines are a little confusing, but currently ACHA tells you universally one target BP that is less than 130/80 for everyone. So this is the one that is associated with low mortality. And if you want to know the drug choices, if the patient is having proteinuria, then definitely there is no doubt you have to give ACE inhibitors or angiotensin receptor blockers only. If the patient is not having proteinuria, then you can consider other drugs also. Other drugs, or you can give ACE inhibitors also, no problem. So, but if the patient is having proteinuria, then the first choice will be ACE inhibitors or ARBs only. But what is the indications to withhold ACE inhibitors, or what are the indications to stop ACE inhibitors? As I told you, if the serum creatinine becomes, or if the patient develops hyperkalemia beyond 5.5, after starting ACE inhibitors, I told you before starting, if it is more than 5, I tend not to start ACE inhibitors. But after starting, the cutoff becomes 5.5. I think we have discussed that already in the previous sessions itself. Potassium is more than 5.5. I tend to withhold ACE inhibitors for a while. And if the patient's serum creatinine rises by certain value, can anyone tell what is the serum creatinine rise beyond which I need to stop ACE inhibitors? I need to withhold ACE inhibitors. I think I've told this already. People who have listened to the previous lecture must be able to tell this. What is the cutoff? No. 2.5 is for mineralocorticoid receptor antagonist for spironolactone. I told if the serum creatinine rises by at least 30% from the baseline, or if the EGFR reduces by at least 25% from the baseline. So this is a very important cutoff. So these are the indications to withhold ACE inhibitors or angiotensin receptor blockers if this is the case. So this is all about blood pressure. And next we have the fifth one, that is metabolic acidosis. Metabolic acidosis, which is very important to control. Remember, indication to start. You can start with soda bicarbonate tablets. Soda bicarbonate tablets can be started. Indication to start is serum bicarbonate less than 20. The serum bicarbonate less than 20, which means there is evidence of acidosis, then you can start with soda bicarbonate tablets. And the target target serum bicarbonate is 22 to 24. Remember, beyond 24 is actually harmful. You should not do that. You should not keep a serum bicarbonate target of more than 24. It's better to keep in the range of 22 to 24. Clear indication to start is serum bicarbonate less than 20. And sixth important problem is hyperkalemia. Many of the CKD patients are going to suffer from hyperkalemia. There are two things that you can do. One is low potassium diet. That's very important. There is a list that we give to the CKD patients which is having potassium, which is having less potassium. So give a low potassium diet. And the same time for CKD management, we use the potassium binding resins, potassium binders. That's the typical treatment. We don't use the more aggressive treatments like insulin dextrose and all. We use only potassium binders in CKD. We have 3 potassium binders which I have seen already. One is SPS, sodium polystyrene sulfonate, otherwise called as Kyaxalate. Second one is Patriumar, which is also available in India. The third one that is not available in India is sodium zirconium cryosilicate. We have discussed that already. SZC stands for sodium zirconium cryosilicate. In that, SPS is the most commonly used resin in India, but it's not having that much efficacy. At the same time, it is associated with a lot of side effects like coronary necrosis and intestinal perforation as well. Whenever the patient is having hypertension, definitely you should give a low sodium diet as well. This is very, very important. Low sodium diet. And number 7, volume overload state. Volume overload state can be tackled with diuretics. Typically, we prefer loop diuretics, but they need a very high dose. Because there is a diuretic that needs to enter into the lumen to start acting. In a CKD patient with a poor GFR, these drugs typically won't enter the lumen that easily, so that it's very difficult to act from inside the kidney. So that's why you need to give an extremely high dose of loop diuretics to have a good effect. Otherwise, they won't be effective at all. But there is one group of drugs which does not need to go into the lumen to start acting. What is that group of drugs? Can anyone tell? These are the diuretics that need not enter the tubular lumen or need not enter the kidney as such to produce an effect, which means they can produce effect from the basolateral side itself. What is that diuretic? No. ENaC blockers also needs to enter the tubules. Yes, MRS. MRS can be given at standard doses because MRS need not enter into the tubular lumen. They act from the basolateral side only. They act on the aldosterone receptors inside the cell. They need not be present on the tubular lumen. So that is also the reason MRS are very dangerous in CKD patients. Especially MRS are contraindicated if the serum creatinine is 2.5 and above. Any serum creatinine 2.5 and above, MRS are contraindicated. At the same time, one more drug you need to know that diabetic drug, as I told you, many diabetic drugs can be given in CKD. But one diabetic drug that should never be given in CKD is metformin. Metformin is contraindicated if the serum creatinine is more than 1.5. To be precise, if it's more than 1.4 in females and more than 1.5 in men, this is the actual contraindication. But metformin should never be given in any patient with serum creatinine more than 1.5 or if the EGFR is less than 60. EGFR less than 60 or serum creatinine more than 1.5, it's better to avoid metformin in these patients. That's very important contraindication. So metformin is not a very good option in patients who are suffering from CKD. That's what you need to know. So volume overload can be tackled. And there are some special problems in CKD which you need to tackle. So one is anemia in patients with CKD. Anemia of CKD, very important problem to tackle. So remember, I told you anemia is due to many reasons. Yesterday we discussed. It's due to iron deficiency. It's due to erythropoietin deficiency. At the same time, it may be due to bone marrow fibrosis, due to hyperparathyroidism. So many things we need to really consider before starting to treat anemia. But nevertheless, HB less than 9 is extremely unusual in patients with CKD. Unusual. HB less than 9 is extremely unusual. Any H hemoglobin of less than 9, you have to always evaluate for iron deficiency or any other cause of anemia. Like probably patient might be having severe gastritis, bleeding. Patients might be having GAVE, that's called gastric antral vascular ectasia. That's very common in CKD patients. So there will be some source of bleeding will be there if the HB is less than 9. Especially if the HB is less than 7, then definitely you can take it for granted there will be some iron deficiency, in the sense like there will be some bleeding. It's very unusual to have HB of less than 9 in CKD, even though HB of 8, 7.5 can be seen in chronic tubular interstitial disorders. Chronic tubular interstitial disorders, because I told you yesterday, chronic TAN only you will have a severe anemia. So it can be a little severe, like 7.5, maybe 8 in chronic tubular interstitial disorders, but usually it is, around 9.5. So that is a hemoglobin that you generally have. So the most important problem to note in CKD patients is if the hemoglobin goes less than 9, there is an increased risk of CHF. Heart failure risk is very high. If the hemoglobin is more than 12, then there is a very high risk of cardiovascular events. In the sense like thrombosis risk is very high. So MI risk is very high if the hemoglobin becomes more than 12 because of hyperviscosity. So if somebody asks you what is the target hemoglobin as far as the CKD patients are concerned, I'll keep a target of 10 to 11.5 maybe. So this could be the ideal target. So less than 9 is also dangerous. More than 12 is also dangerous. So we have to keep a very narrow target of 10 to 11.5. So this is enough for CKD patients if you want to treat them. So whenever a patient is coming with anemia and a CKD, anemia, and the patient is having a chronic kidney disease, the first thing I need to see is whether the iron stores are adequate or not. So if iron stores are okay, I'll tell you what I mean by okay. Iron stores are okay, then you can directly start with ESA, erythroid stimulating agents. If the iron stores are not adequate, not okay, then in this situation I have to first give IV iron, then only I have to go for erythroid stimulating agents, ESAs. So what are the indicators of inadequate iron stores? There are two indicators. One, if the TSAT is less than 20%, or if the serum ferritin is less than 100. Remember, normal ferritin is 10 to 200, but in CKD patients, we need to create a higher cutoff of ferritin because ferritin being an acute phase reactant, CKD is an inflammatory state and ferritin will be elevated in CKD patients. So you cannot keep a cutoff of 10 or 20. You need to keep a higher cutoff of 100. Suppose if the patient is on dialysis, on renal replacement therapy, then the cutoff can be 200 also. Because RRT, the ferritin levels will be even more higher. So if the patient is on dialysis already, then keep a cutoff of even 200, that's fine. So if the iron stores are okay, defined as if the transferrin saturation is more than 20%, or if the serum ferritin is more than 100 at least, then you can straight away start with erythroid stimulating agent. There are multiple erythroid stimulating agents available. Multiple ESAs available. One is the standard recombinant erythropoietin called as epoetin alpha, which is having a short half-life. It can be given, usually it is given IV, it is not given subcutaneously, but you can give IV or you can give subcutaneous also. But you have to give multiple times. You have to give typically 3 times per week. That is the little annoying thing here. Usually we start at a dose of 80 to 120 international units per kilogram. And this dose will be given 3 times per week. This dose will be divided and given 3 times per week. The total dose is 80 to 120. This will be divided and given 3 times per week. The standard dose for what we start is 100 units per kilogram. Typically, we give 5,000 units. That is divided 3 times per week. So that is how we give. Or 5,000 units every week is also fine in certain situations. But in reality, we have to give it 3 times per week. That is 80 to 120 units per kilogram to start with. Second drug, what we have is darbepoetin alpha. Darbepoetin alpha. Darbepoetin can also be given IV or subcutaneous, but typically we prefer giving subcutaneously. The dose depends. Either you can give once per week, or you can give twice per week. Sorry, once in 2 weeks. How can I write once in 2 weeks? I can write Q2 weekly. Once in 2 weeks. Either one per week or once in 2 weeks also you can give. If you're using one per week, then the dose will be 0.45 milligram per kilogram. If you're using one in 2 weeks, one injection in 2 weeks, then you have to give a higher dose of 0.75 milligram per kilogram. In my hospital, typically it comes at a dose of 40 milligram. So generally, I tend to give at once in 2 weeks kind of a distribution only. So 0.75 milligram per kilogram. So what is the IV ion of choice? Any IV ion can be given. For example, iron sucrose, you can use iron carboxymaltose, that is ferric carboxymaltose, or even iron dextran is also there. You can use that also. Or usually we don't use iron gluconate. Iron gluconate we don't use in general because of its extremely low concentration of iron. Iron gluconate is outdated. And the second thing that we don't use is isomaltose. Isomaltose has the highest concentration of iron among all the available formulation, but still we don't use isomaltose very commonly because it's not available in all the centers. Iron dextran, once again, it's completely not popular in India right now. So either clinicians use iron sucrose or clinicians use ferric carboxymaltose. So these are the two things they are going to use in the common practice. As far as how much iron you should give, we have a separate formula, how much iron should be replaced. The advantages of these, especially this ferric carboxymaltose injection, is you can give all at once. You need not wait for a long time, or you need not correct step by step. You can actually give everything at once is fine. So not a problem at all. So how will you calculate how much iron you generally need to replace at once is given by formula, that is 2.2 multiplied by 14 minus hemoglobin plus 1000 milligram. So this is the standard formula for IVA in replacement. Even for pregnancy or even for any other situation, this is the standard formula, 2.2 multiplied by 14 minus hemoglobin multiplied by body weight plus 1000 milligram for the dose. This is what you're going to use. Suppose if the patient is having hemoglobin of 8 and a male patient with a body weight of probably 70 kilogram, then if they ask you how much iron you need, IV iron you need, it is 2.2 multiplied by 14 minus hemoglobin is 6. 14 minus 8 is 6, multiplied by body weight is 70 plus 1000. So here I think I'll be getting 154 into 6, somewhere around 924 plus 1000. I'll be getting around 1924, I think, if I'm not wrong. Maybe I just calculated 1924 milligram is what you get. So which means this patient will be needing approximately 2000 milligram of IVN. So when I'm going to use ferric carboxymaltose, which is the most commonly used in our country right now, many brand names are there. Oro for FCM, NC Carb, so many brand names are there. So that's what the nephrologist is going to use very commonly. I can give just in 2 doses, like for example, 1000 milligram shot and another 1000 milligram shot. Enough. That's all. Most of the time, we don't exceed that, even though the calculation comes to 1924. I don't generally give more than 1000 at a time because I feel it's enough most of the times, because most of the patients will not be that deficient, and if you replace 1000 itself, that will take care of the iron in the body. So usually most of the nephrologists, I've been working under so many of them, so they don't give beyond 1000. So usually they give 1000 and they leave it off and they start with erythroid stimulating agents. So this is the dose of IVN. If you want to really calculate how much IVN is required, this is the one that you need to calculate. And these are the erythroid stimulating agents. And the third one that is coming up is methoxy pegylated epoetin beta. This is a polyethylene glycol form, pegylated form, peg epoetin beta. So this is not commercially available right now in India, but it is being said that this can be given only once a month or twice a month max. So 1 to 2 times per month is more than enough subcutaneous. So they're having more half-life. That is probably one reason why this might become popular in the future. But apart from that, these are the two things that we are currently using in India right now. Epoetin alpha is having the highest receptor specificity. When you take the receptor specificity for erythropoietin receptor, epoetin alpha is the one that has the highest receptor specificity, because this is nothing but a recombinant erythropoietin. That's why they bind very avidly to the receptor. Even though the half-life is a little less, you need to give 3 times per week. But nevertheless, this is the one that has the highest receptor specificity, to be precise, compared to other two components. Other two components have a higher half-life, so you need to give at a lower frequency. So which means the patient might be little okay with that. The compliance might be a little better. Apart from that, epoetin alpha is the one that has the highest receptor specificity because of high receptor binding, because it's a recombinant erythropoietin. As far as the side effects are concerned, the first side effect is hypertension, which is the most important, the most common side effect as far as ESAs are concerned, because they produce increased RBC, so viscosity will increase and hypertension will increase. In CKD, it will be manifesting as a worsening of the pre-existing hypertension. So this worsening of hypertension in CKD patients because of ESA does not mean you need to stop the erythroid stimulating agents. You can just continue with the erythroid stimulating agents, and you just need to add your antihypertensive drugs more and more. You just can intensify the antihypertensive regime, but you can just continue with the ESAs, no problem. Slightly increased risk of thrombosis is there, but not very significant. Still, you can give. So if you keep a cutoff of less than 12, then this is not a big deal. So you can still give ESAs, no problem. But slightly increased risk of thrombosis, especially when your hemoglobin becomes more than 12 grams per deciliter. So this is the evaluation and management of anemia and CKD. And erythropoietin is very important. I think we have discussed that erythropoietin already. So when you take a bone, you know very well, initially you form something called a CFUE, that's colony forming erythroid, that comes from a blast forming unit erythroid, becomes a CFUE. CFUE goes through a series of steps and becomes a reticulocyte. This reticulocyte comes out of the bone, and they become mature RBCs in a variable period of time. So to become mature RBC, it takes around 1 to 1.5 days very commonly. Remember the fact that for stabilization of this CFUE, or for survival of this CFUE, you need erythropoietin. Erythropoietin is needed for CFUE survival. Without erythropoietin, the colony forming unit erythroid cells will not survive. If somebody in exam asks you which cell is completely dependent on erythropoietin for survival, it is CFUE. Remaining cells are also affected by CFUE. Remaining cells are also, remaining progenies are also affected by erythropoietin to some extent, but not like CFUE. CFUE is the one that will survive only if erythropoietin is present, otherwise they won't survive. So for other maturation, you need erythropoietin, and you need other survival factors also, like iron, B12, folic acid. So many other things are also needed for further survival of this and further maturation, especially rather than calling survival, for further maturation of this colony forming unit to maybe a pro-normoblast or to a early, intermediate, late normoblast. So you would have studied in pathology. So for maturation of all these stages, you need erythropoietin, iron, B12, folic acid and all. But EPO for CFUE is the most important. So they survive only with erythropoietin, otherwise they don't survive. So that is the reason why all these things are equally important. When you have erythropoietin deficiency in patients with CKD, your CFUE won't survive, and the reticulocyte count will drop, and the mature RBC count also will drop, resulting in anemia. Similarly, if you have iron deficiency, it's the same thing that's going to happen. Even though CFUE survives, but the maturation will be inadequate, and the reticulocyte count will drop, and the mature RBC count also will drop, and that is the reason why in iron deficiency, the RBC counts will actually be low. That's why iron deficiency, B12 deficiency, erythropoietin deficiency, folate deficiency, all these things will come under hypoproliferative anemias, not hyperproliferative anemias. They'll be coming under hypoproliferative anemias because they don't have a sufficient nutrition for their maturation. Clear? So this is what is going to happen. So if somebody asks you what are the RBC progenies that is unaffected by B12, folic acid, iron, or erythropoietin, that is reticulocytes and the mature RBCs. Once reticulocytes are formed and once the mature RBC is formed, your erythropoietin, iron, B12 doesn't matter at all. So this reticulocyte and mature RBC survival is not dependent on the erythropoietin or iron. It is dependent on other peripheral factors like activity of the spleen and the pathologies that are present in the periphery. So that will take care of the survival of this mature RBs and the reticulocytes. But erythropoietin and the nutrients which we talked about as such is not going to predict the survival of this reticulocyte and mature RBCs in the peripheral areas. So erythropoietin is not going to dictate the survival of the mature RBC. Very important question in exam. So that's why initially we think about iron deficiency first, and then we are going to think about giving a ESA. If there is no iron deficiency, then only I can give an ESA. In the presence of iron deficiency, even if I give an ESA, it doesn't work really because there is a maturation block. Even if I give more and more erythropoietin, doesn't matter. My CFUE won't survive. CFUE will survive, but it will not mature into a reticulocyte or a mature RBC. So they will ask you how to differentiate iron deficiency anemia versus an anemia of chronic kidney disease. We know anemia of chronic kidney disease and anemia of chronic disease both will behave in a very similar way. The first thing is in anemia of iron deficiency anemia, you'll have a extremely low hepcidin which is undetectable, whereas in anemia of chronic disease there will be a high hepcidin, which is the one that is actually blocking the iron absorption. At the same time, that is the one that is blocking the iron release from the reticuloendothelial system. Iron release from the reticular system, because hepcidin does this by blocking one important transporter. What is the transporter? What is the transporter that hepcidin blocks? Yes, ferroportin. Ferroportin is a very important transporter that hepcidin blocks, which is a portal for iron release into the blood. So that's what happens in anemia of chronic disease, anemia of chronic kidney disease. So as far as the hemoglobin is concerned, it can be decreased in both, no problem. As far as the RBC count and reticulocyte count is concerned, it will be decreased in both. That also won't make any sense. Reticulocyte count also follows the RBC count, we know that. And at the same time, if they ask you about the transferrin saturation, that can also be decreased in both. And if they ask you serum iron, that can also be decreased in both. But there are two things that are quite different here. One is the TIBC, that generally tends to be increased in patients with iron deficiency anemia. Second is in anemia of chronic disease, it will be decreased, whereas or maybe normal, but it will be decreased normal, it will not be increased. The most important is the serum ferritin, of course. Serum ferritin levels are basically very, very low in iron deficiency anemia, whereas serum ferritin levels will be either normal or most of the times will be increased in patients with anemia of chronic kidney disease or anemia of chronic disease. Maybe 2 points if you need to know, I will talk about this hepcidin and serum ferritin only. We have soluble transferrin receptors also. Transferrin receptor levels will be high in patients with iron deficiency anemia, whereas transferrin receptor levels will be low in patients with CKD. Maybe normal or low, that's what I'm going to tell, but definitely transferrin receptors will be high in patients with iron deficiency anemia. Because the transferrin receptors are high, the total iron binding capacity is also high. Because the transferrin receptors are normal or low, the total iron binding capacity is also normal or decreased in patients with anemia of chronic kidney disease. So these are differences between anemia of chronic kidney disease. And this is how you manage a patient with anemia of chronic kidney disease. I think this must be more than enough for your exams as well. And the ninth problem that you're going to deal with is metabolic complications, that is especially CKD, mineral bone disorder, metabolic complications in patients with CKD. So whenever you take metabolic complications in patients with CKD, there are so many problems that you need to tackle. Most of the problems of CKD MBD will be due to the secondary hyperparathyroidism. So this is the usual reason for development of this metabolic bone disease or mineral bone disease, CKD MBD. First of all, we need to integrate the vitamin D metabolism with parathyroid metabolism to know this better. To start with, you have a skin. This is where I start with. You have skin with hair, and you have the UV rays that is coming from the sun that converts this metabolites to something called a cholecalciferol. So once the cholecalciferol is formed, it comes into liver, and this liver has something called 25 hydroxylase enzyme. 25 hydroxylase enzyme that converts this cholecalciferol to 25 hydroxy cholecalciferol. So 25 hydroxy cholecalciferol is also coming from many dietary sources. Your dietary vitamin Ds like ergocalciferol can also get converted to 25 hydroxy cholecalciferol. So majority of the dietary sources of vitamin D also becomes 25 hydroxy cholecalciferol, which means 25 hydroxy cholecalciferol is a marker of dietary vitamin D. Usually a marker of dietary vitamin D or vitamin D that is actually produced in your body as a result of diet or exposure to sunlight. So that's what happens. So this is also referred to as something called a calcidiol. So this 25 hydroxycholecalciferol now will be further processed by the kidneys. We know in the proximal convoluted tubule, in the PCT, you have an enzyme called 1-hydroxylase enzyme or 1-alpha hydroxylase enzyme. So you remember 1-alpha hydroxylase looks like a K, kidney. So that's why I remember 1-alpha hydroxylase from the kidney. So this 1-alpha hydroxylase converts this 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol 125 DHCC, which is also referred to as something called as a calcitriol, which is nothing but the active vitamin D. Active vitamin D. This is not a dietary vitamin D, this is an active vitamin D. This is the one that acts on many different areas. The primary area of action is, of course, the intestine, especially in the proximal portions of the intestine like duodenum, where they tend to increase the calcium absorption as well as the phosphorus absorption. That's what they're going to do. But for us, for time being, the calcium absorption is more important. So what happens in patients with CKD is there will be a good dietary vitamin D. Calcium levels may be normal in these patients, but doesn't matter. But because the kidneys don't function properly, the amount of active vitamin D formed is very low, and the amount of calcium that is absorbed is extremely low. That is going to result in hypocalcemia, low calcium. And at the same time, please understand one of the important kidneys function is to excrete phosphorus. Excrete phosphorus, that is really, really important. That's a very important kidney function, excretion of phosphorus. And usually the kidneys basically reabsorb phosphorus through a compound called sodium phosphate transporter. At the same time, first of all, phosphorus has to be filtered by the kidney in order to excrete this into the urine. So, I mean, usually what happens in patients with CKD is they will not be able to excrete the phosphorus because of the poor GFR. They used to retain the phosphorus. And second problem that is going to happen in these patients is hyperphosphatemia. So that hyperphosphatemia is basically due to poor excretion, due to diminished GFR. And low calcium and to an extent high phosphorus definitely becomes a very powerful stimulator for the parathyroid glands. These parathyroid glands have something called calcium sensing receptor, which senses this low calcium. This low calcium is going to activate this calcium sensing receptor. And from the parathyroid gland, you are going to get a surge of PTH, hyperparathyroidism. This kind of hypocalcemia stimulating high parathyroid hormone is what we refer to as a secondary hyperparathyroidism. That's what is going to happen. It's not a primary, it's a reaction to low calcium, so it's called a secondary hyperparathyroidism. And remember, high phosphorus is also a trigger for PTH, but even though it's not a very good trigger like low calcium, but hyperphosphatemia is also a very important trigger because PTH action, you know very well. PTH action is to retain calcium and to thrash phosphorus outside. That's why PTH is also called as phosphorus thrashing hormone or a phosphate thrashing hormone, because PTH retains calcium and throws phosphorus out. But if somebody asks you how PTH is able to throw the phosphorus out, it's quite simple. PTH is going to inactivate a transporter, because in the kidney, I told you one important transporter is that's called a sodium phosphorus transporter. That is very important for retaining phosphate in the body. Sodium phosphorus transporter, which is very important for reabsorbing phosphate from the urine. So the PTH actually throws the phosphate out of the system by basically inhibiting the sodium phosphate transporter. So by inhibiting the sodium phosphate transporter, PTH is basically going to uh, reduce the phosphorus absorption, thereby increasing the phosphate excretion in the urine. So this is what is going to happen with the PTH effect. But the problem is, despite the patient is having a high PTH here, high parathyroid hormone, this is quite unlikely to happen in a CKD patient because the kidneys are already like retaining so much of phosphate, and this sodium phosphorus transporter is already a waste, and PTH action is not going to excrete more and more phosphate nevertheless, because the kidneys are already failed and they're going to retain a lot of phosphorus in the body. So this hyperphosphatemia also will not resolve. At the same time, the problem with this hyperphosphatemia is they can keep on combining with calcium, and they'll be producing more calcium phosphate, and they'll be decreasing and depleting the calcium again and again and again. So that is one more problem with the high phosphorus. At the same time, this high phosphorus is going to do this high parathyroid hormone is going to do one more thing. It's going to work on the bone. In the bone, they can, in fact, if you know the endocrinology properly, PTH can stimulate both osteoblasts as well as osteoclasts. Suppose if PTH is given at intermittent low doses, your osteoblastic activation will be more than osteoclastic activation. If PTH is given at physiological doses, like what happened in physiology, your osteoblastic activation will be equal to osteoclastic activation. If PTH is given at continuous and high doses, your osteoclastic activation will be more than osteoblastic activation. As far as intermittent low dose is concerned, it is basically bone protective. Physiological doses, basically it is bone remodeling. Continuous and high doses are basically bone destroying. This is not bone protecting. This is basically bone destroying. So clear? So, but in the setting of CKD, what happens is, in the setting of continuous hypocalcemia, the parathyroid or glands are going to work continuously, and they're going to produce very high levels of parathyroid hormone for a long period of time. So which means it's your balance is going to become something like this. You're going to result in a continuous high parathyroid hormone for a long time, which typically becomes bone destroying. There will be serious osteoclastic stimulation, and that's going to cause severe bone resorption, resulting in bone disease. And this bone resorption will result in increasing of the, will try to increase calcium, but they will not increase calcium. That is the idea of this high parathyroid hormone in the first place. They are trying to increase calcium, but it does not happen. So, nature is very beautiful, isn't it? So if you want to increase calcium, you need to eliminate phosphate. So otherwise PTH can't do that. So that's why PTH also tries to eliminate phosphorus through the urine, but that does not work because the kidneys are not functional here. So that is the reason they cannot do that very correctly. So the phosphorus that is coming from the bone with the effect of PTH, normally they try to move out of the kidney, because even though PTH increases the phosphate release into the blood from the bone, but it will be indirectly removed from the body through this inhibition of sodium phosphate transport in the kidney. But this kidney mechanism is no longer working. So this increased phosphorus will persistently cause more and more hypocalcemia, and this more and more hypocalcemia will result in more and more stimulation of parathyroid gland. This more and more stimulation of parathyroid gland will produce more secondary hyperparathyroidism. More secondary hyperparathyroidism will result in more osteoclastic stimulation. More osteoclastic stimulation will result in more and more resorption, and more resorption will result in more phosphorus, less calcium, and this vicious cycle will keep on going again and again and again. So you will not stop this hypocalcemia also. You cannot stop this hyperphosphatemia also, unless and until you clinically intervene with some of your therapeutic options which are available. And this is not it. There are so many other problems that are happening. Like, for example, if you know, this 125-DHCC can be inactivated by another enzyme called 24-hydroxylase, which produces 1,24,25 hydroxycholecalciferol. So this is actually an inactive form of calcitriol. So why I told, I'll come back to that in some time. So there's one more thing that senses this low phosphate. Can anyone tell what is the cell that senses this high phosphate, this phosphorus? This phosphorus is basically sensed by one important cell within the bone. What is that cell that senses the phosphate? That senses the phosphorus. Not phosphodone. I'm not talking about the cell. That cell that senses the phosphorus, osteoblast. Osteoblast is the one that senses the phosphorus in the cell. In response to this phosphorus, the osteoblasts release a substance called phosphotonin. That one of the phosphotonin is the FGF23. So that is fibroblast growth factor 23. This is also really important. I think I can write in a different color only this. Will be sensed by the osteoblasts and they'll release something called FGF23. This is a phosphotonin. So what FGF23 does is it tries to, actually FGF23 is like a homeostatic compound which is released in response to phosphate, which means the role of FGF23 must be to reduce the phosphorus in the body, which means it's released as a result of high phosphate. So its role must be to reduce the phosphorus in the body. So FGF23 basically tries to activate this sodium phosphorus transporter so that you can trash more phosphate out of the system. And second thing, what FGF23 tries to do is it tries to activate the 24-hydroxylase enzyme so that you can reduce the calcitriol levels in the body. Thereby, you can actually prevent the phosphorus absorption from the intestine, because if you have a less number of 120 active vitamin D, you can actually reduce the amount of phosphorus that is getting absorbed from the intestine. So actually FGF23 is not caring about calcium, it's only caring about phosphorus. So what it has to do is it has to try and activate this, try and inactivate this sodium phosphorus transporter so that you can trash more phosphate out of the system. At the same time, it tries to inactivate the vitamin D so that you will have less phosphorus absorption. It doesn't care about calcium, nevertheless. So what really happens here is this mechanism on the kidney will not work because already the kidneys are damaged here. So this mechanism is failed, but it can effectively activate this 24-hydroxylase and can worsen the functional vitamin D deficiency that is already there in the patient by preventing the calcium and phosphorus absorption. Remember here, the phosphorus absorption from the intestine is not that important because the phosphorus is already retained. So that does not make any sense. But this mechanism of FGF23 by inactivating more and more vitamin D is basically going to worsen the calcium absorption more and more and more, and it's going to worsen the hypocalcemia to a large extent, and it's going to cause a lot of problems. So there are two mechanisms that are happening side by side. One is the secondary hyperparathyroidism, and second is the FGF23 related mechanisms also. So typically the FGF23 is directly proportional to mortality in CKD patients. The more the FGF23, the more advanced the CKD is, and more higher is the mortality of the patient. So this is something which you need to know. FGF23 is directly related to mortality. Point number one. At the same time, to treat this bone disease, you need to control the calcium as well as you need to control the phosphorus as well. So then only the entire spectrum of bone disorders will resolve. Otherwise, it's not going to resolve nevertheless. So how can you really treat this bone disease? So the idea is to increase the calcium and to reduce the phosphorus. So how will you increase the calcium? At the same time, you need to reduce the phosphorus as well. So to increase the calcium, you need to give calcium supplements. At the same time, you need to give vitamin D supplements as well. And this vitamin D, you have to make sure that it is calcitriol and it's not calcidiol. So give vitamin D supplements. At the same time, give calcium supplements as well. To reduce the phosphorus, you have to give phosphate binders. Phosphate binders has to be given. So what are the phosphate binders that are available? There are many different types of phosphate binders that are available. One is calcium-based phosphate binders. Typically, what we use is something called calcium acetate. Calcium acetate can be used. And second is non-calcium-based phosphate binders. In this, we have metal-based and non-metal-based. Non-metal-based. Metal-based, we had so many compounds were there previously, including aluminum-based compounds. Then we have so many other like binders are there, but non-metal based is the one that is currently very popular, and one of the important non-metal based compound is sevelamer. This is the current drug that is very commonly used as a phosphate binder, and this non-metal based, non-calcium based phosphate binder have shown to increase survival compared to the calcium based phosphate binders. But we have non-metal based phosphate binders also. Like for example, we have one more thing, that is lanthanum hydrochloride. Lanthanum is actually a metal-based one, but aluminum-based substances are not used nowadays because of well-known documentation of aluminum toxicity. Right now, we use only non-aluminum-based metal-based phosphate binders like lanthanum hydrochloride, if at all. But currently, like even lanthanum is not preferred. We only prefer sevelamer hydrochloride, sevelamer HCl. So that is the usual phosphate binder that we prefer in the current era. So, but nevertheless, you can give phosphate binders and you can reduce the phosphate in the blood. At the same time, you can increase the calcium by giving calcium and vitamin D supplements to a large extent. So this is what I'm going to do. So this is what I'm going to do and control the bone destruction and control the secondary hyperparathyroidism by giving calcium and by reducing the phosphorus in the body. And because of the persistent osteoclastic stimulation, one more problem might evolve. Because the persistent osteoclastic activation, one problem that might evolve in this patient is that brown tumors. Because this is due to severe osteoclastic hyperplasia and proliferation of osteoclasts. Locally, they can result in this brown tumors. Brown tumors are a sign of very high parathyroid levels in the body. It can happen in primary hyperparathyroidism as well as secondary hyperparathyroidism. There are multiple names for this CKD mineral bone disorder. Previously, we called it as renal osteodystrophy. Currently, we don't call that as renal osteodystrophy. And areas of bone loss in the spine has been typically called as something called as rugged jersey spine. You would have seen in a lot of radiology images in the past. So I don't want to really talk about that as well. So these are very old names: rugged jersey spine, renal osteodystrophy. We do these kind of terms. We don't use that. Currently, we use spectrum of problems called as CKD mineral bone disorder. Because if you take a CKD mineral bone disorder, it's not just you're going to deal with hyperparathyroidism related bone destruction. You're going to deal with a vitamin D deficiency related osteomalacia also. And there is another problem also you're going to deal with, that is called an adynamic bone disease. So many problems you're going to deal with. So if somebody asks you what do you mean by adynamic bone disease, that happens due to massive reduction in the PTH levels. So to understand what is adynamic bone disease, you need to understand one important thing, that parathyroid hormone is basically a natural compound that is present within the body. So if it's a natural compound that is present within the body, if it's acting continuously on a particular receptor, for example, let us assume it's acting continuously on the PTH receptor. Continuously on the PTH receptor, PTH is acting for a long time. This PTH receptor basically is going to get down-regulated over a period of time. It's not going to consistently work. It's going to get down-regulated after some time. So if it gets down-regulated after a period of time, now actually, in order to maintain the bone, so I told you physiological amounts of PTH is important for just bone remodeling. That's normal bone turnover itself. You need some amount of PTH that is necessary. It's not like PTH is dangerous. PTH is actually beneficial if it's present at physiological levels, which means it's going to promote bone turnover, and it's going to give a good bone remodeling at physiological states. So if the PTH receptors are down-regulated, basically you need a higher PTH to maintain a normal bone turnover. To maintain a normal bone turnover and normal bone remodeling, you need some high PTH if the PTH receptors are down-regulated. That's what happens in CKD MBD patients. At very high levels, fine, it's dangerous. But because of this continuous high levels, the PTH receptors will be down-regulated, so that you will be needing a high level of PTH to maintain a normal bone turnover. Suppose if I'm giving this calcium, phosphorus supplements and I'm trying to reduce the PTH and I bring the PTH to lesser range, in a CKD patient, we know already the PTH receptors are down-regulated. And now suddenly you reduce the PTH to such a low value, and the bone might lose its turnover and the bone remodeling might completely stop. And that is what we refer to as something called as a adynamic bone disease, otherwise referred to as a ABD, adynamic bone disease. So that is why there are some PTH targets for different stages of CKD. For example, if you have a CKD stage 1, for example, so 1, 2, 3, up to stage 1 and 2, the PTH targets doesn't matter. You can maintain a normal PTH Stage 3, you can keep a PTH target of approximately 35 to 70 picograms per ml. Suppose if you have a CKD stage 4, you can keep a target of 70 to 110 picograms per ml. Suppose if you have a CKD stage 5, then you can keep a cutoff of 150 to 600 picograms per ml. So if you see one important observation here, if you move from 3 to 4 to 5, the PTH targets are actually increasing. And that's really important because in advanced stage of CKD, if you try to over enthusiastically reduce the PTH, you will result in something called a adynamic bone disease, where the bone turnover itself will be lost and you'll not be able to produce a proper bone strength. So there are so many problems that are happening in CKD patients. One is the secondary hyperparathyroidism that is destroying the bone. Second is the vitamin E deficiency that is causing osteomalacia that is destroying the bone. And third is adynamic bone disease that can happen if you over enthusiastically reduce the PTH levels by giving calcium supplements and phosphorus binders, thereby causing a loss of bone turnover resulting in adynamic bone disease. So secondary hyperparathyroidism, ideally the bone turnover will be high. Bone turnover will be high. In adynamic bone disease, the bone turnover will be low, whereas in osteomalacia, the bone turnover will be normal. So usually the bone turnover will be normal in the setting of osteomalacia, high in the setting of secondary hyperparathyroidism, and low in the setting of adynamic bone disease. But nevertheless, even though this is given for differentiating purposes, but all these three things can happen in the same patient at the same time. So that is why you need to really, consider all these things in as a uniform perspective, and you have to treat everything. Secondary osteomalacia is very easy to treat. If I give a good vitamin D, then that osteomalacia will be okay. Secondary hyperparathyroidism, I know I have to control the PTH. At the same time, I need to know how much I have to lower the PTH to avoid this adynamic bone disease. So which means using this PTH targets and using simple treatments like calcium, vitamin D, and phosphate binders, you can achieve all these things. But don't forget this PTH cutoffs, which is very important. If you go below this PTH cutoff, there is a high risk of developing adynamic bone disease. Then you need to really worry. Be careful about that. I think now you will be understanding about this FGF23 based mechanisms and secondary hyperparathyroidism that can result in development of CKD mineral bone disorder. But apart from that, this hyperparathyroidism can also be controlled by one more thing that is called as cinacalcet. There's other options to control hyperparathyroidism, that is secondary hyperparathyroidism, that is cinacalcet is there. Cinacalcet is basically it's a calcium sensitizer. I can tell it's a parathyroid calcium sensing receptor agonist, so which means it stimulates the calcium sensing receptor. So previously we know that because of the low calcium, only you are getting high parathyroid hormone. But this cinacalcet, it works like calcium, and they are going to work on the calcium sensing receptor, and they make the calcium sensing receptor believe that the patient is having a good calcium in the body, so that they down regulate the PTH production. So this cinacalcet is a drug that's going to work like calcium on the calcium sensing receptor. So they make the calcium sensing receptor believe that there is enough adequate calcium in the body, so they down regulate the PTH production. So this is one more option that is there, where you can use something called a cinacalcet. And finally, if the PTH levels are uncontrolled despite all your basic interventions, then you can go for parathyroidectomy. Parathyroidectomy is the final option. So if the PTH levels are uncontrolled, you cannot control PTH levels despite all your medical management, then you can go for parathyroidectomy. There are two indications for parathyroidectomy. One is if the serum PTH is more than 800 despite optimal medical treatment, despite medical therapy. Second is if there is any evidence of tertiary hyperparathyroidism. I'll come back to that, what do you mean by tertiary hyperparathyroidism, if there is any evidence of tertiary hyperparathyroidism. Number three, if there is any evidence of parathyroid adenoma or hyperplasia, any tumor in the parathyroid adenoma. So these are definitive indications of parathyroidectomy in a patient who is suffering from a chronic kidney disease. So these are three indications. In that, in a usual CKD patient, the first one may be a good indication. Despite medical management, if the PTH levels are still more than 800, then you can chop the parathyroid glands out and you can do a parathyroidectomy in this perspective. But doing a parathyroidectomy is not again very simple because there are supernumerary parathyroid glands. Patient, even though in the anatomy textbooks beautifully will see only 4 parathyroid glands, there might be so much of parathyroid glands in the patient. That is, some axillary parathyroid glands may be there, which can still create a problem. So again, how to treat a hyperparathyroidism through parathyroidectomy is a different, question and different scenario that we are not going to discuss right now. So, but serum PTH more than 800 may be a good indication to do a parathyroidectomy in patients with hyperparathyroidism, in patients with CKD. But nevertheless, final table that I want to tell is you have to differentiate between primary hyperparathyroidism, secondary hyperparathyroidism, and the tertiary hyperparathyroidism. So as far as the primary hyperparathyroidism etiology is concerned, usual etiology of primary hyperparathyroidism is your parathyroid adenoma, which is the commonest cause, followed by hyperplasia, parathyroid hyperplasia, or it could be a carcinoma also, which is extremely rare. If it's a secondary hyperparathyroidism, it could be either due to vitamin D deficiency or a CKD. These are only two reasons, very common. Chronic kidney disease. Tertiary hyperparathyroidism, usually the reason is CKD only, there is nothing else. Usually tertiary hyperparathyroidism will be identified post-transplant. Most of the time, tertiary hyperparathyroidism will be identified post-transplant only. I'll tell you what is the difference between primary, secondary, and tertiary. So what is the pathology, pathophysiology? It is autonomous parathyroid gland that is producing excessive parathyroid hormone unnecessarily. As a secondary hyperparathyroidism is concerned, it is a response to low calcium, response to hypocalcemia, which means already the primary problem here is hypocalcemia, not the parathyroid. Here the problem is parathyroid has become autonomous and they're not hearing anything and they're straight away starting the PTH secretion in a very high level. So in tertiary hyperparathyroidism, it is two things: a secondary hyperparathyroidism or a secondary hyperparathyroid gland becoming autonomous. So it's like a mixture of primary and secondary. It's a secondary gland only. It's like it's responding to hypocalcemia, but over a period of time, because of continuous stimulation by hypocalcemia, your gland has become autonomous. It's like a mixture. So that's what we called as a tertiary hyperparathyroidism. Here also the gland is actually autonomous only. The gland is basically autonomous only here. Okay. So if we take the serum calcium levels and serum phosphorus levels, alkaline phosphatase levels, and PTH levels. So what will be the finding? So as far as the serum calcium is concerned, serum calcium will be high, phosphorus will be low, alkaline phosphatase will be high, PTH levels also will be very high. So here the primary problem is high PTH that is causing hypercalcemia, hypophosphatemia, and elevated alkaline phosphatase because of stimulation of the osteoblasts. Similarly, in secondary hyperparathyroidism, the low calcium is the primary problem, and that is going to raise the PTH levels, and alkaline phosphatase levels also will be elevated in this setting because of the high PTH. Alkaline phosphatase will be elevated because of stimulation of osteoblasts, but the phosphorus levels are quite variable. It can be increased or it can be decreased. So this is the most important difference. Suppose if it's a CKD patient, phosphorus levels will be very high. If it's a vitamin D deficiency, phosphorus levels will be low. We know that. We know that very clearly because in vitamin deficiency, the phosphorus and calcium will be low because of poor absorption. In CKD patient, we know that calcium will be low, but phosphorus will be high. Why calcium low? Because of low production. Why phosphorus is high? Because of increased retention of phosphorus because of the poor kidney function. So in exam, if they give a low calcium with a high PTH, you have two differential diagnoses. To tell whether it's CKD or vitamin deficiency, always see phosphorus levels. Phosphorus high means it's CKD, phosphorus low means it is vitamin D deficiency. Then in a tertiary hyperparathyroidism, your PTH levels will be extremely high usually. Alkaline phosphatase levels also will be very high. But calcium and phosphorus levels are variable here. Calcium and phosphorus levels are variable. Usually in exam, it will be very simple. They will give normal or even increased calcium they'll give a normal or even increased calcium, or they'll give a normal or even a decreased phosphorus, which means it might actually mimic like a primary hyperparathyroidism. If you see, these values usually mimic like a primary hyperparathyroidism, but you know very well, suppose if a patient is having a CKD, correcting a calcium, or if the calcium becomes increased, the natural response should be PTH should be suppressed. If it's secondary, this should be the response. Once you correct the calcium and once you correct the phosphorus, the PTH should be suppressed. And that's what should happen. PTH should be suppressed. But if you still see a very high PTH, despite correcting the calcium and phosphorus in a patient who's already having a secondary hyperparathyroidism and patient who's already having a CKD, then it must not be a secondary hyperparathyroidism. It must be a tertiary hyperparathyroidism only. That is why most of the times we know that once you do a transplant, so you have did a transplant, post-transplant, of course your PTH should be corrected, because one of the important and the best treatment for correcting PTH and any disturbance in a CKD patient is a transplant. After a transplant, your PTH should correct. After a transplant, if your PTH is still high, that indicates a tertiary hyperparathyroidism. Tertiary hyperparathyroidism is an exclusive complication of CKD. It doesn't happen in any other situation. That's why written here, only complication of CKD is, tertiary hyperparathyroidism happens only in CKD, not in anything else. Very, very important point to know. Clear? It happens only in CKD, does not happen in any other situation. So usually identified post-transplant. After the transplant, you expect the PTH to come down after normalization of the calcium and phosphorus and all. But even after normalization, if still your PTH levels are persistently high, even after a transplant, then it's not a simple secondary hyperparathyroidism. Now there is an additional problem where the glands have become autonomous. That's why they're not respecting calcium and phosphorus anymore, and they're continuously producing more and more PTH, resulting in a tertiary hyperparathyroidism. That's why it's usually identified after the transplant. Remember, the treatment of choice for tertiary hyperparathyroidism is parathyroidectomy only. As far as treatment is concerned, once again here it can be medical or it can be surgical. Surgery means I'm going to do a parathyroidectomy. As well as surgery is concerned, I need to see whether the patient is symptomatic or not. What are the indications for surgery? One is symptomatic patients is a best indication for surgery, or the patient has syndromic hyperparathyroidism, especially for example MEN syndrome. MEN 1 syndrome is a classic example. MEN 1 syndrome and MEN 2A to be precise. MEN 2A, both these syndromes have hyperparathyroidism. So if it's syndromic, then definite indication for surgery. Or if it's symptomatic patient, any symptomatic patient, like what are the common symptoms of primary hyperparathyroidism? Stones, groans, moans. So what is stones? Renal stones. It's the most common symptomatic presentation. Most of the patients will be asymptomatic only, even in primary hyperparathyroidism. But few patients may be symptomatic, and the most common symptom is stones, renal stones. Then is abdominal groans, that is abdominal pain. One is due to hypercalcemia causing constipation. Second is hypercalcemia producing more histamine release, producing more acid and peptic ulcer. So abdominal groans and psychic moans, that is due to basic ganglia calcification causing psychiatric disturbances. So this is a classical problem. Apart from that, you can result in ectopic calcifications. In the sense, like, we don't call ectopic, that's metastatic calcifications in it. So that can also result in a lot of other problems due to primary hyperparathyroidism. High calcium in primary hyperparathyroidism can produce distal renal tubular acidosis also, which I have discussed in the previous session. So many problems can happen in primary hyperparathyroidism. But what surgery you do, it depends. In a primary hyperparathyroidism, you can, if it's a single adenoma, single gland involved, for example, if you have an adenoma, then in this setting, you can go for a simple, minimally invasive parathyroidectomy. Minimally invasive parathyroidectomy, which is usually can be done under ultrasound guidance, not a big deal at all. If it's multiglandular, best example is MEN syndrome again. MEN syndromes, you'll have multiglandular involvement. If it's a multiglandular involvement, then you have to do a total parathyroidectomy. You can do either a subtotal or a total parathyroidectomy, but typically it's the total parathyroidectomy that is preferred. So if they ask you what do you mean by total parathyroidectomy, we generally try to remove the 3.5 glands and leave only half gland. What half gland to remove depends on table gross visualization. So whichever is the gland that looks the most normal, The most normally appearing gland in gross examination during surgery is the one that is left behind. Half of the gland in that gland will be left behind. So even though some people tell it's the superior parathyroid gland, right superior should be left behind. Half of the gland, that's very old concept. The current concept is on table you examine all the parathyroid glands and which gland looks the most normal, you can leave half of that particular gland in situ and remove all the remaining 3.5 glands, and that is what we refer to as a total parathyroidectomy. And in total parathyroidectomy, leaving half a gland means it doesn't mean that half a gland will be left in the parathyroid area. That will be usually taken out, and you will be using a forearm graft. Either you can place in the brachioradialis, under the brachioradialis, or you can place in the tibialis anterior also. In the leg also you can keep. Typically in the forearm or in the leg. In the forearm means brachioradialis. In the leg means you will be placing in the tibialis anterior muscle. So that is where you place basically. So this is total parathyroidectomy. Subtotal parathyroidectomy means you will remove 3 to 3.5 glands, and that remaining gland will be left in the neck itself. So that is subtotal parathyroidectomy. But currently, they prefer doing a total parathyroidectomy with a forearm graft or a forearm or a leg graft. So that is what they prefer doing. So that is for multifocality. But remember, before doing a parathyroidectomy, it's always better that you always we need to know whether it's single gland or multi-gland. So you need to localize which gland is abnormal. So localization studies include, maybe you can do a Sestam scan. That's a technetium based scan. Technetium 99M Sestam scan. And you can use 4D CT, 4-dimensional CT. Both should be done. Because of a lot of reasons which you'll be studying in your surgery textbook. So you need to do a 4-dimensional CT along with Sestam scan. Both should be interpreted together to find out which are the glands that are abnormal, which are the glands that are normal. As far as secondary hyperparathyroidism is concerned, I'm going to use medical management only. If refractory, then I can go for a parathyroidectomy. Once again, the parathyroidectomy I'm going to prefer is doing a total versus a subtotal parathyroidectomy. That's what I'm going to use. In a tertiary hyperparathyroidism, there is no medical management role for medical management. I'm going to do a parathyroidectomy, total or a subtotal parathyroidectomy straight away. There is no doubt about that. So that's what I'm going to use. As far as medical treatment is concerned, indications for medical treatment: number one, asymptomatic patients, medical management; and second, patients not willing for surgery. Not willing for surgery. Despite having indications, I'll be treating with the medical management only. So this is the indication of medical, surgical, and for secondary, what you need to do, and for tertiary, what you need to do. That is parathyroidectomy. So this is how you manage a hyperparathyroidism in reality. But for our kidneys, you need secondary and tertiary to be at your fingertips. This is what you need to know as far as the kidneys are concerned. So this is another special problem that we deal with, isn't it? CKD-MBD. And anemia of chronic disease, I think the basic, all the other problems we have discussed already. Diabetes, hypertension. Actually, treatment of CKD is quite simple. It's not difficult at all. But if you know the concepts properly. And there are a few things which you need to know. All the important things I told you already. Do you understand what I've told till now? Yes. Good. Okay. Okay. When to start dialysis in a CKD patient? So we have different types of dialysis which I have discussed already, but when to start with dialysis? Uh, we called about maintenance dialysis, isn't it? I think yesterday I would have told about the maintenance dialysis in a little bit of detail. I told you some indications to start with the maintenance dialysis, but nevertheless, as the maintenance dialysis is concerned, most often performed technique is IHD, internal hemodialysis only, or you can do a peritoneal dialysis also. Peritoneal dialysis, we do typically something called a CAPD, that is called a continuous ambulatory peritoneal dialysis. This is what we do. So where we put a catheter and that will be there, and there will be a dwell time. Typically, as far as PD is concerned, um, the dialysate composition is very important. At the same time, how long it should dwell within the peritoneum is also important. For example, the typical infusion time is 10 minutes. The dwell time is around 1.5 to 5.5 hours. And the removal time is around 20 minutes. So it can be done overnight also. So there are a lot of variations in that is there. But the advantage of this continuous ambulatory peritoneal dialysis is the fact that it is extremely convenient for the patient. You can do it from home itself. I mean, of course, even the doctors are not willing to come to the hospital nowadays. How come you expect a patient to come to the hospital all the time? So it's very convenient. So they can do it from home. And there are some patients who actually demand for a home dialysis, in the sense like they want to do hemodialysis, but they are willing to do from home itself. So there are some affordable patients where we can set the home dialysis setup where they can have a nurse and they can do the dialysis from home also. We're not talking about those kind of things. We're talking about a very normal, average, middle class man where he has to be convenient at the same time. He doesn't want to come to the hospital that much. So in that setting, you can go for a continuous ambulatory peritoneal dialysis for that matters. As far as the peritoneal dialysis is concerned, first we need to know the infusion time. So infusion of dialysate will usually take 10 minutes approximately, as I told you some time back. Then there is something called a dwell time. There's something called a dwell time. Dwell time in the sense like we'll leave the peritoneal dialysate inside the peritoneum so that the exchange of the components will happen. So that will be approximately 1.5 hours to 5.5 hours, typically 1.5 to 5.5 hours. It can be done overnight also, or you can use a overnight dwell also. I mean, it is more convenient for the patient. Rather than waiting, you can just sleep and leave the fluid inside the abdomen. Sleep, and in the morning, next day, you can remove that. Remove the dialysate. Dialysate removal will typically take around 20 minutes. So this is what we do. This is how we do a peritoneal dialysis. And as far as the PD fluid is concerned, there is a slight difference as that of the original hemodialysis dialysate. PD fluid will contain, as I told you, slightly higher dextrose, not slightly, in fact, a very high dextrose. But this is very important because this is the one that produces that osmotic pull, and they draw water, and along with the water, they are going to produce a solvent drag, which drags a lot of solute as well. So you have different types of concentration. So varying concentrations of dextrose can be used depending on the situation, and it does contain a buffer in the form of lactate. And lactate, even if it is getting absorbed, it's going to go to the liver and they can produce that bicarbonate. So it can be effective in acidosis as well. That's why we're using that buffer as a lactate. And they do contain some amount of sodium, calcium, as well as magnesium, depending on the patient's demands. So this is the composition of the PD fluid. But the most important to know is this dextrose. That's very important component. And this is also associated with one important side effect, that is hyperglycemia. So PD is associated with the worsening of diabetes control and even severe hyperglycemia, especially on the dialysis days. So that's one thing that you need to know about the PD fluid. Apart from that, there is one peculiar complication of PD fluid, that is PD peritonitis. PD peritonitis, because of the catheter, you can result in infection, that is a PD peritonitis. Most of the times they might be asymptomatic, or they might be associated with an abdominal pain, doesn't matter, but you won't get severe abdominal pain. Usually it will be less severe. Even if they get abdominal pain, it will be less severe. You will not get the pain like what you get in a routine peritonitis, like severe pain. It's not like that. So it will be very little pain, not that much pain. At the same time, most of the patients can be completely asymptomatic. But usually the first sign of this PD peritonitis, if they ask you, that is a cloudy peritoneal fluid. Cloudy peritoneal fluid, I told you, like when you infuse, you dwell for some time and remove after some time, this removed fluid will be looking cloudy. So this is what we refer to as a cloudy peritoneal fluid. And if you examine the cloudy peritoneal fluid, this peritoneal fluid will contain more than 100 WBCs with more than 50% of the neutrophils. With more than 50% of the neutrophils. So this is the definition of PD peritonitis. Whenever the WBC count in the peritoneal fluid dialysis, when remove the fluid, the peritoneal fluid contains more than 100 WBCs, and if the neutrophils are more than 50%, this is what we define as a PD peritonitis. And the most common organisms they will ask you, usually gram-positive organisms like Staphylococcus. Staph is the most common organism, that is gram-positive coccus. It can be sometimes gram-negative organisms also like Pseudomonas, but gram-positive organisms like Staphylococcus are the most common. And as far as the treatment is concerned, treatment is usually conservative. You need not basically remove this peritoneal dialysis catheter. You can give a IV antibiotic, or some situations you can give a intraperitoneal antibiotics also, but in our setup we prefer intraperitoneal antibiotics. How can you give intraperitoneal antibiotics? You can just infuse the antibiotic. For example, vancomycin can be injected into the dialysate. That dialysate can be pushed into the peritoneal fluid, peritoneal cavity, and you allow to dwell that peritoneal dialysate with antibiotic for 3-4 hours, and then you remove that. It's like washing the peritoneum with antibiotics. So you can use intraperitoneal antibiotics also. That's also fine. You can use any of these antibiotics, and plus or minus removal of the PD catheter. So PD catheter will not be removed in all the situations. PD catheter will be removed if the culture shows certain specific organisms like Candida, number one, and second is Pseudomonas. So if the culture shows Pseudomonas or if the culture shows Candida, then in that situation we can probably remove the PD catheter. Otherwise, there is no indication to remove the PD catheter in reality. There are some other problems associated with PD. Second is something called a sclerosing peritonitis is there. Because of the continuous irritation by the PD fluid and the PD catheter, peritoneum can go for reactive sclerosis, thickening, and the pores that are serving as dialysis membrane in the peritoneal membrane can get closed, and you can no longer achieve the peritoneal dialysis efficiency. So we call it as sclerosing peritonitis. Sclerosing peritonitis. This usually happens in patients who are using peritoneal dialysis for a long time, maybe for years together. This will happen. And remember, to have peritoneal dialysis to be effective, you should have some residual kidney function. Some residual function of the kidneys is mandatory for peritoneal dialysis to be effective. So that is what we refer to as something called a minimal residual function, MRF. What do you mean by minimal residual function? Which means patient's urine output should be at least more than 100 ml per day. So this is called minimal residual function. So to have this PD to be effective, you should have at least that minimal residual function to be intact. So if minimal residual kidney function is also not there, then peritoneal dialysis is unlikely to be effective. At the same time, there are many other problems associated with peritoneal dialysis. They cannot take the solutes that easily, and solute removal is very slow and very unpredictable in peritoneal dialysis compared to hemodialysis. So it has its own limitations, but overall, it's a very good option because it's low cost. Patient need not come to the hospital. You get an independence from the hospital. At the same time, it's more convenient, and the patient side compliance also will be a little better. But there is one interesting study which told that there is no significant difference in mortality when you compare with hemodialysis. When you compare CAPD with hemodialysis, overall in long term, we're not talking about a short term solute and all this stuff. In the long term, maybe at the end of maybe 6 months or 1 year, if you see, there's no significant change in the mortality versus hemodialysis. So which means in patients who wanted to be independent and wanted to be convenient, and patients well educated, they know how to manage this PD catheter, peritoneal dialysis, especially this continuous ambulatory peritoneal dialysis, is a very good option. CAPD. Then as we talk about the intermittent hemodialysis, that is IHD, the first thing they will be asking is how many times you need to do the intermittent hemodialysis per week or maybe per month. Usually the more you do, the better it is. Anything that is associated with less than 2 times per week means higher mortality. This is very important to know. So you should never keep a cutoff of 2 per week or 1 per week. Very high mortality. So minimum you should need to do 3 to 6 times per week. So in reality, 6 times per week, I don't think patients will accept in our setting, especially the patients having home dialysis, where they can dialysis in home itself, then 6 times per week may be okay for them. But many patients who are coming to hospital, this 3 times per week is the one that is usually optimal. Minimum you need to give 3 times per week, and the total duration of dialysis must be approximately around at least 9 to 12 hours per week. So this is the total duration. Remember, both should be satisfied. It doesn't mean that you can give 6 hours 2 times. No, that's also not valid. The total duration of dialysis is usually 9 to 12 hours per week, and it should be at least 3 times per week minimum. So typical prescription, what we do in our hospital is 4 hours of sessions, 3 times per week. So this is what we do. This is the classic prescription of dialysis, 4 hours of dialysis, 3 times per week. This is a classic prescription. This is what we are going to do. So usually this is the usual thing that we do for most of our patients. And try to do alternative days. Don't try to give a gap of more than 2 days, which is also having a higher mortality. So try to give a gap of only 1 day or maximum 2 days, not more than that. Try to do alternative days of dialysis. So this is the classic prescription. 3 times per week, 4 hours. Minimum 12 hours per week is mandatory. Clear? So what are the complications? What are the complications of hemodialysis? So one is, of course, you need vascular access. One of the important advantages of peritoneal dialysis is you don't need a vascular access. But as far as this hemodialysis is concerned, you need a very good vascular access. And this vascular access can be based on the catheter. Number one, first vascular access is catheter. Catheter means, I told you, you can put a double lumen catheter in a IJV or maybe in the femoral region. You can start the subclavian. We don't prefer, I told you. So catheter. So there are some advantages as well as disadvantages. Catheter is almost immediate. You can achieve immediately. Immediate access is possible. There's no waiting time at all. But one important side effect of this catheter is it's extremely high risk of sepsis, because it's directly accessing the central veins. So, and it's a catheter is an external structure. So there is extremely high risk of sepsis, and flow will not be adequate. So there will be lesser flow in the catheter through the catheter because you are pushing into the veins. The veins naturally will have less flow. Even though you use that motor and suck out a lot of blood, but still the flow will not be that great to achieve a good dialysis. So reduced flow means your efficiency of dialysis will be very less. Reduced efficiency of dialysis because of less flow, because it's venous flow. That is the reason. But one biggest advantage is immediate. That's the biggest advantage. Second, we have something called a standard AV fistula. AV fistula. Usually many sites you can do AV fistula, but the classic site is, the classic and the most commonly used site is the radiocephalic fistula. Radiocephalic fistula. This is the classic site where I'm going to use the AV fistula, radiocephalic fistula. This radiocephalic fistula is also referred to as something called as Semino-Brescia fistula, who got Nobel Prize in 1950s for discovering this AV fistula. This is the one that changed the life of the CKD patients. Radiocephalic fistula. Here, usually we use the non-dominant hand. We don't use the dominant hand because we know why. So usually we prefer doing it in the non-dominant hand, which will not interfere with the patient's regular activity. So for me, my dominant hand is right. So I'm going, if it's me, I'm going to use, I'm going to be fistulized in the left hand, not the right hand. So non-dominant hand, radiocephalic is the classic site. But if radiocephalic is not accessible, then you can go for brachiocephalic fistula. Brachiocephalic is not Semino-Brescia classic, but still you can use this brachiocephalic fistulas as well. Either radiocephalic, Semino-Brescia, or brachiocephalic fistula. Advantages of AV fistula are enormous. Like for example, it has the highest patency of all, which means a properly maintained fistula can be maintained for up to 7-10 years also without any problem. If you are maintaining the fistula properly, as per the recommendations, as per the advice from the doctor, you can maintain this fistula for almost 7 years, 10 years, even 15 years. There are some patients who maintain this fistula properly. Very low risk of sepsis because it's peripheral and it's venous. No foreign bodies are there consistently inside the blood vessel, so it's extremely low risk of sepsis. At the same time, it is associated with the lowest mortality among all. That's why this is very good. But one problem that you're going to face with AV fistula is the fact that it's going to have a maturation time. You have to have some waiting time. It takes some maturation time, which means today you connect the arteries and the veins through surgery. Vascular surgeon is very important here. You always get a vascular surgery consult where they fix the case and electively they operate and they connect the artery and the radial artery and the brachial vein together. I mean, cephalic vein together. So which means it will not mature immediately. So it needs some maturation time. The veins has to become compliant, they have to become big. So you will have some maturation time. Usually it is around 1 to 6 months or 2 to 6 months. This is the usual maturation time. And there is a risk of non-function. There is something called primary non-function. So usually 1 in 5, risk of non-function is approximately 15 to 30%, which means 1 in 5 individuals may not, have a maturation of the fistula, which means the maturation might not happen and they will fail the surgery. So you need to do a resurgery. So this kind of problems are there, but the waiting time is the key. So it takes around 2 to 6 months. That is the reason why whenever the patient enters that late CKD, that stage 4 CKD, you better send the patient to vascular surgeon to do a fistula, because you don't wait till the ESRD to happen, because once ESRD happens, you need to take the patient for dialysis. So don't wait till that. Even in CKD stage 4 itself, you counsel the patient for putting a fistula and be ready when the time comes, because it takes a long time, 2 to 6 months to mature it. At the same time, third option, in patients, we close the fistula post transplant? No, really. So we don't really close the fistula post transplant. The reason is because we might be needing dialysis even after the transplant. Like especially there is something called delayed graft function. So suppose after transplant, if the patient doesn't get the function within a week, that's called a delayed graft function. After 1 week, if the patient initially the graft function is good, but after 1 week, if they get a graft failure, that's called an early transplant dysfunction. If the patient gets a transplant dysfunction after 1 year, that's called a late transplant dysfunction. So technically speaking, we don't really close the fistula. We just keep the fistula for some time. But if the patient doesn't develop any complications for the first 6 to 12 months, after 1 year, probably we might try to leave it off. We don't really need to cut off and close the transplant. If you just don't maintain the fistula properly, automatically it will close after some time. So that's not a big deal. So if you don't maintain, so if the patient really wants to close, then we can close, not a problem. But in reality, we don't really close. We just wait and we keep it intact, because the patient might be needing dialysis at any point of time in the first 6 to 12 months after the transplant as well. So where again exposing the patient to neck veins, if you want dialysis, that creates a lot of problems. So that is the reason why in general in our setup it is advised that not to close the fistula in the first few months, or at least maybe in the first year. I don't really wanted to close the fistula in reality. Okay. As far as the AV fistula, suppose if you cannot do the AV fistula, then we have something called an AV graft. AV fistula, then we go towards something called an AV graft. As far as the AV graft is concerned, so this is used only if the patient is not having a fistula. I mean, cannot be produced a fistula. For example, the primary non-function is happening again and again and again. Try 2-3 times where fistula formation is impossible. Then I can go for a graft. So there are a lot of grafts are there. Currently, we use the company called Hero, HERO. So these kind of grafts is what we prefer. But nevertheless, AV grafts are used only in patients who don't have this primary AV fistula to be formed because of the primary non-function again and again. So this is much easier. That's one important advantage. Shorter maturation time. Maturation time is typically only 2 to 3 weeks. It has a very short maturation time, whereas there you have 2 to 6 months. But nevertheless, they have once again a poor primary patency. Primary patency is very poor. They can go for thrombus very often because it's a foreign material, not a natural material. So they can go for thrombus, which means you need to do an angioplasty, you need to do a thrombectomy. So that's again a problem. So this is a problem with AV graft. AV graft is the less preferred technique. In exam, fistula you will easily identify, not a big deal. But graft is something you need to identify. I'll show you a image probably. I don't know whether I have the image or not. Let me try. Yeah, we do have. So this is how AV graft typically looks like. Probably in an exam, if you see some sort of U-shaped structure like this basically AV graft. So fistula you will identify easily, but graft sometimes it might be difficult to identify. Graft will be a little more prominent, and it's easy to find out. So it will be like a U-shaped one. So that is a connection between artery and the vein. You have a graft that is connecting these two, the radial artery and the cephalic vein. So using that also you can do a fistula, not a problem. So you have AV graft, okay? So suppose if the patient is on a catheter, develops a fever. So patient who's on a catheter develops a fever. Surely you have to start with empirical antibiotics. Surely. Because patient is on a renal replacement therapy, getting any sort of infection, usually there is a high risk of MDR infection. Any patient on hemodialysis or any patient on renal replacement therapy, getting an infection, there is a high risk of MDR organism. Even in pneumonia, if you go back to the pneumonia guidelines and see, patient who's on renal replacement therapy getting a pneumonia, there is a high chance of having a multi-drug resistant organism, MDR organism. So that's why empirical antibiotics is very important. Typically, we give gram-negative coverage. Gram-negative coverage, we can use third generation cephalosporin or probably an extended spectrum penicillin like piperacillin, tazobactam, or meropenem. So some gram-negative coverage is important. But in our setting, we either go for a piperacillin, tazobactam, or probably a meropenem. That's what we give. Second, we give empirical vancomycin. The first shot I told you, irrespective of the creatinine, you can give the first dose of vancomycin, no problem. At the same time, we'll be continuing with the hemodialysis also. Based on the trough levels of vancomycin and based on the kidney function, we can adjust the doses of this antibiotics. Doesn't matter. And the most common organism, once again, is the Staphylococcus. That's gram-positive organism. That's the most common. It could be either a Staph aureus or it could be a Coagulus-negative Staphylococcus. Depending on the organism, we can tailor the antibiotics after some time. And at the same time, whether to remove the HD catheter or not, again, depends on organism. If it's a Pseudomonas or if it's Candida, I have to remove the HD catheter. No doubt about that. I need to put in another place or I have to use alternative methods of dialysis. But if the patient is not having this staph or not having this Candida, then I can leave the catheter in place and I can just try with antibiotics. If the antibiotics doesn't work, then I can try removing the catheter. So in general, the most common organism is staph only. It could be either a staph aureus or it could be a Coagulus negative Staphylococcus as well. So these are the different forms of hemodialysis. Apart from that, hemodialysis itself is associated with some other complications. Like for example, what are complications? We didn't talk about complications, right? So this dialysis related complications. Dialysis complications. We talk about the common complications. I'm not talking about hyperglycemia and all this stuff. We talk about a common complication. The common complication is hypotension. The first common complication is hypotension. Hypotension can be due to many reasons. So usually it is called as intradialytic hypotension. Intradialytic hypotension. Intradialytic hypotension can be due to rapid removal of blood. That is by activation of something called a Bezold-Jarisch reflex. This is the commonest thing. So when you remove the blood suddenly, you will activate the Bezold-Jarisch reflex because the ventricles will contract emptily because of loss of volume, and that will activate the vagus, resulting in severe bradycardia and hypotension. So that is one possibility. Second is it could be air embolism, which is a realistic possibility, even though it's rare with the current filters that we have. Third is anaphylaxis, allergy due to some components that we use. That's again quite rare. And or it could be pulmonary embolism, sometimes very rare again, or it could be some cardiac event, like cardiac failure, like myocardial infarction, which is also common in patients with CKD. But nevertheless, the usual thing that we encounter is this Bezold-Jarisch reflex mediated hypotension. So if this is the case, then what you're going to do is suddenly transiently stop dialysis, stop HD, and you try to give IV fluid bolus. Probably around 250 to 500 ml normal saline must do the job. So this is more than enough. This Bezold-Jarisch reflex, the same mechanism how you get a vasovagal reflex as well. Vasovagal syncope as well. So same mechanism. So just by removing the blood, because of that, you will activate this and will get. So in that condition, stop HD transiently and give IV fluid bolus. and that should settle the debate. And next time, because if a patient gets hypotension, is prone for getting hypotension next time also. So next time, set a lower ultrafiltrate, which means if you set a higher ultrafiltrate, they are actually removing a lot of volume. You know, yesterday itself, I told you what I mean by ultrafiltrate. So use to set a lower ultrafiltrate goal and sequentially increase over a period of time. So this is a typical HD prescription that we do. And ultrafiltrate goals, again, is beyond the scope of the current discussion. I'm not going to talk about that. So you can set a lower ultrafiltrate. So these are the cause of hypotension that can happen. And second problem, you can get malnutrition because of long-standing dialysis. Malnutrition is because of removal of some essential proteins from the body during dialysis. And there could be accumulation of some non-essential proteins also that can result in amyloidosis. That's called a dialysis-related amyloidosis. Dialysis-related amyloidosis. As far as malnutrition is concerned, that is the reason why in dialysis patients, we give a slightly higher protein compared to non-dialysis patients. Non-RRT, you give a low protein, not low, moderate protein. But on dialysis, you give a slightly higher protein because of the risk of malnutrition. This risk of malnutrition actually more with PD patients compared to HD patients. That's what has been proved. And dialysis-related amyloidosis is typically due to beta-2 microglobulin. I think we have discussed on amyloidosis where I told you, typically dialysis-related amyloidosis due to beta-2 microglobulin will result in shoulder arthritis very commonly. They don't result in systemic problem like cardiac involvement and kidney involvement. They tend to produce this shoulder arthritis, which is quite common. So any patient on dialysis coming with shoulder arthritis, think about beta-2 microglobulin related amyloidosis. Fourth is calciphylaxis. Any ESRD patient, on or not on dialysis doesn't matter, but if the patient is on dialysis, there is a higher risk of developing calciphylaxis. That is calcific uremic arteriopathy, which we have discussed yesterday. Number 5, infections we spoke about already. And number 5, you can get DDS. Many things are there, but DDS might be your example. That's called a dialyser disequilibrium syndrome. So what do you mean by dialyser or dialysis disequilibrium syndrome? Usually this happens. Risk factors include first dialysis, when the patient is going for first hemodialysis. During that time, DDS risk is very high, or the patient is having extremely high serum urea, very, very high blood urea nitrogen. So in this situation, you can think these are the usual risk factors for developing a dialysis disequilibrium syndrome. What really happens is, especially when the patient goes for first dialysis, there will be a sudden osmotic shift will be there because so many solutes will be removed. So sudden solute removal. Sudden solute removal. This sudden solute removal will result in sudden drop in the serum osmolality. Sudden drop in serum osmolality. This sudden drop in serum osmolality will cause fluid shift. Fluid shift, typically from ECF to ICF. We know that. The ECF osmolality low means then fluid water usually goes from region of lower osmolality to region of higher osmolality. We know that. So ECF to ICF. And they can go for cerebral edema because of the same. They can go for cerebral edema because of the same, and they can develop CNS symptoms like seizures, altered mental status, headache, so nausea, vomiting. All these things can happen during dialysis. That's called a dialysis disequilibrium syndrome. So remember, treatment is very simple. Treatment is giving a mannitol or a 3% SL. Typically, we use mannitol for this. And next time, our patients who are at high risk of developing DDS, you can give a preemptive mannitol and then start a dialysis. And you can usually set a URR. If you're doing a first-time dialysis, that's something called a urea reduction rate. You can set approximately around 30%. Normal URR that is set in dialysis 65% plus. But to start with, you can set a 30%. So you don't want to reduce that much urea in the first dialysis itself. So that's why to begin with, you can set 30. Then later on, you can go for 65. As far as efficacy of maintenance hemodialysis is concerned, we have two formulas. One is KT by V more than 1.2. So this is the goal. And second is something called urea reduction ratio more than 65%. So these are the two formulas that is there. You might get an exam, and understanding these formulas is beyond the scope of the current discussion. Again, we usually discuss these kind of things in MD level only. There's no need to discuss right now. But just to know the formula, KT by V more than 1.1, urea reduction ratio more than 65%. These are the two things that define the efficacy of hemodialysis when the patient is on a maintenance hemodialysis, typically. So I think this 5 is more than enough. Hypotension, malnutrition, dialysis-related amyloidosis, calciphylaxis, dialysis, disequilibrium syndrome. And there are many other complications that are hard water syndrome, then dialyzer allergy is there. Many different complications are there. Each and everything needs understanding. When you are going to an MD level or maybe even to a DM level, when you're working in the dialysis unit, then that time you will be understanding in a much better way because you are directly getting exposed to the patient. That is different. So as far as the most common cause of death in CKD is concerned, there are certain factors are there. As far as the mortality in CKD, the most common cause of death in CKD patients is typically cardiovascular mortality only, which is approximately around 50%. That's the usual cause of death. Then followed by infection, which is typically around 30%. Then the final 20% is due to withdrawal from dialysis. Which is around 20%. This is the usual cause of death. Most common is, of course, some cardiovascular mortality, heart failure, pulmonary edema, and all this stuff. This is the usual cause of death. And then followed by infections, then finally followed by withdrawal from dialysis. Patient will stop coming for dialysis and because of loss of complaints. And of course, it's expected, understandable from the patient as well, because you cannot expect the patient to keep coming all the time. Sometimes they get frustrated. Depression is also very common in these patients. Cognitive disturbances will happen, so which will all make them very aggressive, and they will tell, don't want dialysis and I will die, and suddenly they will withdraw at one point of time and they will die out of dialysis. So I think the CKD discussion is over. We have discussed everything about CKD. Did you understand about CKD? So that the only thing that is left next is transplant. Do you understand? Okay. Okay, it's time now. We move to the transplant. And before going to the transplant, one other disease that you might be getting in exam is ADPKD, autosomal dominant polycystic kidney disease. ADPKD. And usually ARPKD is something that they won't be asking. As far as ADPKD is concerned, you have two types of ADPKD. One is PKD1 gene related problem, and second is PKD2 gene related problem. PKD1 gene related problem is actually common. And these are the group of patients who are going to get an early ESRD also, early end-stage renal disease compared to PKD2. So there is a risk of early ESRD with PKD1, and it's common, which means 85% of the patients will have genetic mutation in the PKD1 gene only. So that is commonest form. At the same time, they tend to get a little bit of early end-stage renal disease as well. As far as the clinical features are concerned, in exam, you will typically get a family history for sure, because this is an autosomal dominant disorder with a high penetrance, in the sense, no escape. If you have the gene, you will suffer from the disease. Very high penetrance. So surely you will have a family history. Somebody in the family would have died out of, maybe father or mother would have died out of kidney disease, or probably they would have already had a kidney disease and on dialysis. So some sort of family history of kidney disease will be there. At the same time, on examination, you will see large palpable kidneys. Large palpable kidneys, and will be bilaterally palpable. And one of the few areas where you can really palpate the kidneys is ADPKD. The entire abdomen will be full of kidneys. Such a big kidney you will see, full of cysts, easily palpable kidneys. So that's number 2. And number 3, they will ask about the extrarenal manifestations. Extrarenal manifestations. Extrarenal manifestations could be again cysts elsewhere in the body or other complications. So cysts elsewhere in the body, if they ask you the second most common site apart from the kidney, it is the liver. Liver is the most common extrarenal site, but remember, it is usually asymptomatic and they don't result in any problems like cirrhosis or some other problems. So liver cysts are the usual common sites. Apart from that, they can get cysts in the pancreas, they can get cysts in the lung, they can get cysts in the spleen, they can get cysts in many areas. But abdominal organic cysts are very common. For example, spleen, pancreatic cysts are very common. Lung cysts are quite rare. And the more and more you move up above from the abdomen and more away from the abdomen, the cysts will be very rare. Brain cysts are not at all described. In reality, there is 0.03%, very few, like handful of cases, like 15, 20 cases where brain cysts are also have been described. But in reality, in any textbook, there will be no demonstration of brain cysts in ADPKD patients. As you move away from the abdomen, the incidence of cysts will actually reduce. They're talking about the extrarenal cysts. And as far as other things are concerned, you can get berry-aneurysms. And if you remember, I would have told some risk factors for developing berry-aneurysms and subsequent subarachnoid hemorrhage. In that, ADPKD is extremely important. This is where they can get berry-aneurysm. But remember, if they ask you the most common extrarenal manifestation, that is hypertension. Apart from the extrarenal cyst, if they ask you the most renal extrarenal complication, that is hypertension. Hypertension is very, very common in these patients. And this hypertension actually increases the risk of subarachnoid hemorrhage as well. I mean, because more and more blood pressure means more and more enlargement of the cyst and more risk of rupture of this aneurysms and more risk of subarachnoid hemorrhage. So hypertension will definitely increase the risk of subarachnoid hemorrhage. And apart from that, they can get cardiac issues. Cardiac issues most common, if they ask you, answer is mitral valve prolapse. And they also have a high risk of developing intestinal polyps, especially colonic polyps. Colonic polyps risk is also very high. But if they ask you most common cardiac problem in these patients, most common cardiac problem is mitral valve prolapse. MVP is the most common cardiac problem in patients with ADPKD. So these are some of the other important points that you need to know, clinical feature wise. And investigation, we are going to use only ultrasound. Ultrasound is one of the best investigations. It's the first line investigation, screening investigation, best investigation for all this. We are going to use ultrasound only. And even for monitoring, everything ultrasound only. So ultrasound can easily identify the cysts. Alternatives to ultrasound are CT and MRI, which does not provide any much edge at all. And the criteria that we use is modified Ravin's criteria. You can go through that later on. It's not important, for example, just the name. Modified Ravin criteria is the one that we use. Less than 30 years means how many cysts should be there. 30 to 60 years means how many cysts should be there to diagnose ADPKD. And more than 60 years means how many cysts should be there with family history and without family history. We have like a Ghent criteria for Marfan's. We have separate criteria for ADPKD. That's called a modified Ravin's criteria. That is the one that we use as a standard for diagnosing ADPKD. But nevertheless, the cysts are going to be there. One more important thing is if they ask you about the treatment basically is the first line treatment is control hypertension, because majority of these patients will have hypertension. First thing is to control hypertension. For controlling the hypertension, you can use ACE inhibitors or angiotensin receptor blockers, because most of the times this hypertension is RAS mediated. Usually in CKD patients, hypertension is not RAS mediated and it's volume dependent. Because of high volume overload in the patient, that itself will cause high BP in the patient. So that's the usual case. RAS mediated hypertension is quite rare, but in ADPKD, it is usually RAS mediated hypertension. So why? Because this cyst will compress on the adjacent vessels, and this compression of the adjacent vessels will result in hypoperfusion to the glomerulus, and that will result in activation of renin-angiotensin-aldosterone system, causing hypertension. So hypertension is quite common in ADPKD and usually due to RAS, and that can be effectively treated with ACE inhibitors and ARBs. Any one has to be given. You cannot give both, obviously. And remember, young hypertension. Young hypertension means hypertension onset less than 35 years carries a poor prognosis. Severity of the disease will be very high. If the patient develops young hypertension, the disease will be usually very severe and it has with the poor prognosis, one of the important poor prognostic factors. Second treatment, what you can give is, you can use some disease modulating therapies or disease modifying therapies. So there are few drugs that are disease modifying as per the current understanding. One are the mTOR inhibitors. And third is the Vaptans. Typically tolvaptan, one of the important disease modulating therapies. And second is mTOR inhibitors, which is sirolimus and everolimus. These are the disease modifying therapies or disease modulating therapies. Sirolimus and everolimus. These are disease modulating therapies. And again, very important to know as far as exams are concerned, because these are two modern therapies that are approved for treatment in patients with autosomal dominant polycystic kidney disease, mTOR inhibitors and Vaptans. They are found to be very beneficial because the mechanism of cyst formation is based on mTOR pathway, and the vasopressin 2 receptor, V2 receptor pathway. V2 receptor activating cyclic AMP pathway is very important for cyst formation. At the same time, mTOR formation is also very important for cyst formation, because they believe that mTOR pathway is the one that increases the cellular proliferation, and this cyclic AMP mediated opening of the chloride channel is important for fluid accumulation. So, when there is a cellular proliferation along with fluid accumulation, that is what we call as a cyst, isn't it? So, they believe that the cyclic AMP based on V2 receptor pathway is important for fluid accumulation, and the mTOR pathway is important for cell proliferation. That is actually causing the cyst in this patient. So, that's why blocking the mTOR pathway with sirolimus or everolimus, or giving a Vaptan like tolvaptan, is basically associated with the slowing down the progression of ADPKD, which means if somebody in exam asks to slow down the cyst progression in patients with CKD, what are the drugs you will use? I'm going to use mTOR inhibitors and Vaptans, which can naturally slow down the progression of disease as well as the cyst formation. And apart from that, if they ask you the best treatment, it's always transplant only. Best treatment, it's always a renal transplant. Because a genetic disease, once you do a renal transplant, the disease will not come back again. So this is one of the conditions again where there is extremely low risk of developing the disease again. So that is why selection is very important. Most of the times transplant means you will be getting the kidneys from the own relatives, maybe son or a daughter. They are the ones who are going to give the transplant, give the kidney. So that is why transplant evaluation is important. So that's why screening of children or screening of siblings is very important. If they ask you, how will you screen? Suppose if my father is having ADPKD, for example, and I wanted to know whether, first of all, I am a transplant candidate, or I'm having cyst or not, I'm dissing or not. So two things I need to know: whether my father is already having ADPKD, and whether I have a disease or not, I need to know. Second thing, I need to know whether I can donate my kidneys to my father, because he's already suffering from ADPKD and he's a CKD, and at some point of time he needs a transplant. So I need to know these two things. So first, screening is always ultrasound. Always ultrasound. So ultrasound, initial ultrasound can be positive or initial ultrasound can be negative. Initial ultrasound is positive means you have diagnosed already. There is no doubt about that. So initial ultrasound can be negative at times, which means they may not show any cysts, despite the fact that I can already harbor the gene, but still I might not show cysts at a very early age. Maybe my age is only 18 or 19 years. So I may not show the cysts at that point of time. So what should I do now? So I need to know. So what should I do? So I need to see whether I'm a potential transplant candidate or not, or a potential kidney donor. More than transplant candidate, I can write the term potential kidney donor, which means if your idea of screening is to know whether if your idea of screening is to know whether I can donate or not. So that is one idea. Or if my idea is just to know whether I'm a patient who can develop a disease or not. If I'm a potential kidney donor, yes, then next step is genetic testing. That is the best. MRI is not superior to ultrasound in this situation. So you're just going to do a genetic testing, which means if your idea is to know whether I can donate my kidneys to my father who's already on dialysis, end-stage renal disease, so then I can do a genetic testing directly. If my idea is to just know whether I have a disease or not, I'm not a potential kidney donor, then in this setting, it's better you repeat ultrasound after a few years. Typically, we're asked to come at the age of 30 years maybe. At 30 years, you come back. Because the patient is 18 years or 20 years, I ask them to come back again at 30 years. That's all. Why you want to do an MRI in this situation? So anyway, the disease is not going to progress overnight and you're not going to get the disease tomorrow. So it's going to have a long time of latent period and it's going to cook for a long time. So you ask them to come back at 30 years and and rescreen with ultrasound at that time. So that's enough. After a few years, you can ask them to come back and rescreen with ultrasound. There is no point in doing MRI or genetic testing in these guys. So only indication for genetic testing, a patient who is a potential kidney donor having a negative ultrasound. A patient who is a relative of that particular ADPKD patient plus a potential donor and having a negative ultrasound, which means the ultrasound is not showing cyst. So in those setting, you can go for a genetic testing. Why this identifying the cyst is very important? Because if the patient is already harboring the gene of ADPKD, or if the patient is already having cysts in the kidney, they cannot be a transplant candidate because they are already beggars. They will get CKD at one point of time. How can they donate that deceased kidney, or they will be needing that kidneys later on? So otherwise they will go for faster ESRD. So patient who's already having the disease or patient who's already having the gene responsible for the disease cannot donate the kidneys. So to screen for potential kidney donors only we do genetic testing. Otherwise you don't need to do genetic testing. So that's why I told you the first line screening test is ultrasound only. There are few things that determine the prognosis as far as CKD is concerned. The most important and the topmost prognostic factor is the total kidney volume, TKV. That's called total kidney volume. So the more and more the total kidney volume, bigger and bigger the kidneys are, poor is the prognosis. And many other things are there, like young hypertension is there. The number of extra analysis based criteria is also there. But nevertheless, the single most important predictor of prognosis in a patient with ADPKD is the total kidney volume, the size of the kidneys. That's the most important. And apart from that, second most important prognostic factor, if you take the development of hypertension. So development of hypertension marks the acceleration of the disease. The disease will progress and it will accelerate faster, and they'll move towards ESRD at a very fast pace. And again, presence of this gene, whether PKD1 or PKD2 gene. PKD1 common, at the same time associated with the younger, earlier ESRD compared to PKD2 gene mutations. So these are some of the points that you need to know. And this is ADPKD is one example where you have CKD with large kidneys. And one more interesting point, if you note that ADPKD patients actually can do excellently with dialysis. It seems like certain patients like diabetic kidney disease patients do worst with dialysis. They don't really do well with dialysis. But patients with ADPKD and all, they do very well with dialysis. Even for, I've seen patients with ADPKD, they are doing well with dialysis alone for maybe years together without even getting a kidney transplant done. So they can do very well with dialysis. At the same time, the best treatment is renal transplant only. There are very few questions will be there on ADPKD, and these ADPKD patients can develop renal stones also. It's not external manifestation. It should not be written under external manifestation, but you need to know that these patients can develop renal stones as well. They will ask you what is the most common type of stones, renal stones, that you develop in these patients. So what is your answer? They ask you the most common type of renal stones in these patients. In patients with ADPKD, what is the answer? Because it's peculiar, that's why I'm asking that. You typically tend to develop uric acid stones. That's what you develop in a patient with ADPKD. This is quite common, uric acid stones. Because of the high cell turnover, there will be high local hyperuricemia. That will be the cause of developing uric acid stones. Usually 10 to 20% of the ADPKD patients will have stones. And most commonly it will be uric acid stones, not calcium oxalate. Because in community, the most common type of stones is calcium oxalate dihydrate type of stones. But in ADPKD patients, most common type of stones you get is uric acid stones. And there are some complications that you can get due to cyst itself. So complications due to cyst. So there are quite a few complications that you can get. So first complication is cyst hemorrhage. Usually they'll come with pain. So whenever ADPKD patient comes with severe pain, especially flank pain, that is more acute in onset, think about a cyst hemorrhage. And typically it is treated with percutaneous drainage, more often conservatively treated. But if the patient complains of severe pain, you can actually try treating it with the percutaneous drainage. And easily, by doing a CT itself, this can be diagnosed easily, not a problem. And second is cyst infection. Cyst infection is actually quite difficult to treat. It can come with fever, flank pain, and plus or minus hematuria can be there. But usually, whenever you take this isolated cyst infection, urine cultures may be negative. Urine cultures may be negative. It may not be positive because it's a localized cyst infection. Usual organism is once again E. coli only. Gram-negative organisms are the common reasons for cyst infection. But the problem is you need a very long-term antibiotics, long course of antibiotics to treat this cyst infection. Plus or minus, you need to give a percutaneous drainage also. You have to poke the cyst and you have to take the infected fluid out, plus or minus. And you need a long-term antibiotic. Usually we give a quinolone, like levofloxacin. These are two important problems. The major problem is pain alone. Think about cyst hemorrhage. The major problem is fever and a vague pain in the loin area. Think about a cyst infection, especially if they give urine culture negative in the exam. Think about a cyst infection. Cyst infection, it's difficult to treat. You need a very long-term antibiotic. At the same time, you might be needing a percutaneous drainage of that infected cyst as well. So you need to identifying the cyst is also quite difficult. You don't know which cyst is infected because there will be hundreds of cysts sometimes. So which cyst is infected, you will not be knowing. So to identify which cyst is infected, you need to know the PET-CT. PET-CT, whichever cyst is actually having high uptake of the glucose, then you can think about that cyst is actually infected, and you can actually go for drainage of that particular cyst. There are many other sequences are there, but usually the best scenario, you do the PET-CT and identify the cyst that is infected and poke it and drain the cyst if it is infected. But usually you can try treating conservatively with antibiotics initially. But the problem is the cysts are basically non-penetrable areas by the blood. So it's very difficult to penetrate by your antibiotics. So you need to give a very high dose and long-term antibiotics. Typically use quinolones like levofloxacin. But nevertheless, these are the two complications that can originate due to the cyst itself. And what are the exam questions? Maybe exam questions may be based on this diagnosis, this most common external site for cyst, most common cardiac problem, risk of subarachnoid hemorrhage, presence of colonic polyps, and the newer drugs that we are using to reduce the progression of ADPKD, and cyst hemorrhage and cyst infection. How will you screen? What is the best investigation to screen a patient with ADPKD? And probably which is actually asked with earlier ESRD, that is PKD1, not PKD2. So these are the usual questions. And one more thing, that uric acid stones. Many times asked question. Uric acid stones are the usual type of stones that you get in patients with ADPKD. These are the usual questions that you get in exam from ADPKD. Apart from that, you have another disorder called ARPKD, that is autosomal recessive polycystic kidney disease. It's very easy, like because the patient will be having a very younger ESRD, like around 2 years, 5 years itself. In younger childhood itself, they are going to get the ESRD within the first decade. And at the same time, they'll be having multiple extrarenal complications, like they might be having Caroli's disease, that is a form of choledocholecystis. They might have a Caroli's disease, or they might have liver fibrosis, because in ADPKD, the extranal cyst will not give rise to any problem. But in patients with ARPKD, the extranal cyst also will have a complication, like especially this Caroli's disease and liver cirrhosis, liver fibrosis, you need to know. So liver fibrosis, Caroli's disease, early ESRD, but more importantly, in autosomal recessive polycystic kidney disease, they will have a normal kidneys, normal sized kidneys. Even though when you cut and see, you can see the cysts, that will be a radial arrangement of the cysts. You would have studied in pathology. So I don't want to tell because it's not my domain. So there will be a radial arrangement of the cysts, but the kidney size will be normal. The kidney size will not be increased. That's one important difference. And the extrarenal cysts also create complications like liver fibrosis and Caroli's disease in the setting of ARPKD. And usually the patient gets ESRD within first decade. So as soon as they are born, they're born with kidney disease in this situation. So that is ARPKD, which is a more severe form of cystic kidney disease. So I think with this, I'll give a short break. And after this, we'll be moving ahead with the transplant. So I hope whatever I told you till now, you have understood. We'll come back in some time. Maybe at 7 o'clock, maybe we'll start the session. I'll intimate nevertheless.